addresses on George E. Weems Memorial Hospital Board of Directors meeting. Our vision is providing quality care close to home. You know what? That's good, because we're opening a pharmacy in Carabel. That kind of rings true, doesn't it?
It's kind of close to home.
Huh?
That's close to
That's
home.
close to home. So, proud of that. April 30th, 2026 at 9 o'clock a.m. Please note this meeting will be video and or audio recorded. First thing is call to order. We do have a quorum. And did we get the stuff posted properly?
Yes.
Notification posted,
Yes.
okay? Next item is the public comment. Do we have any public comment? No public comment. Next item is approval of the minutes. Do I have a motion to approve the minutes from last meeting?
Motion.
Do I have a second?
Second.
Do I have any discussion? If not, all in favor?
Aye.
All
Aye.
opposed? Okay. My next item on here is is customer service. How are we doing in customer service? Are we working on it? What are we doing, actually, concretely?
Yeah, well, I think, you know, we're working on-
Concrete, and this thing about, well, this is.
Well, I'll give you a good example right now.
Good.
First of all, we enrolled our staff in some customer service trainings.
Good.
You know, we'll begin to look at that as well. But one of the things happened the other day, Courtney and I was in our office meeting, and a lady walked through and it seemed like she was confused, you know, at that time. And she was walking in the hall. So Courtney began to talk to her and tell them what happened, Courtney.
She was a elderly lady from the east end of the county. He was there from mammogram, and she was about 30 minutes early. And she ended up getting in a different entrance, so she wasn't directed. So she's wandering around, and then her anxiety was high by the time we saw her in the hall. She was right outside my office. And so we got her and took her to the front and got her scheduled with admissions. And then she and I started talking about fingernail polish and stuff to redirect her, because I was trying to calm her down. We had the same fingernail polish, but it was just kind of trying to redirect her mind. Anyway, and so we got her scheduled or for her appointment, and then I went and let Nancy know that she was there early, and Nancy's our memo tech, and she was able to accommodate her and get her in early so we could kind of get her calm. And then when Nancy finished with her, she brought her back to me, and the lady had parked over in staff parking. So then I take her out to her car, and she's way over there in the staff parking by Disc Village, kinda. And I'm standing in the bushes trying to watch her to make sure she gets in her car safe. And
Okay.
after a while, she's still sitting there, so I go over there and check on her. She's on her phone, tells me she lives on kind of close to Carabel. So then I stand there about 10 more minutes, make sure she's safe. She says she's good to get home and tells me her address. Then I stand there a little bit longer and check on her again. Anyway, long story short, then when she finally leaves, and then I call her about an hour later to make sure she got home, and she did. But anyway, things
You didn't call?
like
You
yes,
called
and
her?
she made it home. Yeah, and she was thankful. But you know, she was anxious about her appointment, and then she was just anxious, and she was obviously a little confused, even though she was awake, alert, and oriented, person, place, time, all those things, because she parked over there in in the staff parking and such. So. Anyway, little things like that all the time.
That's very nice, you know. I mean, you got to realize how confusing things can be to people.
Sure.
When I go to TMH, I park on the top floor of the parking lot. You know why? I'll know where my truck is. I'll get an elevator, that whatever, I'll know where my truck is, you know. I mean, I can find my truck, you know, the top thing, and when I go to visit somebody, I'll park up there, you know. So it can be then you got the A trip, you got people can be very confused, so.
Yeah.
Yes.
So it's our job to.
They even get confused in our tiny little place. So.
Well,
And it's not, you know.
I have a comment for you on customer service. Colleen was over at the hospital the other day, and I think what we have to really realize when we talk about customer service, I know you did a great job with that person, and that's the personal hands-on we want to see, but I think you got to also train up the front-end staff. There was a couple that came in, as Colleen tells me, They were elderly and they were trying to get an appointment, and the person behind the desk was not trained. He was a substitute because one of the people didn't show up that was supposed to be there, and he did not know anything about anything. And he had to ask these people 3 or 4 times what they were there for. He didn't know how to connect the people to the services that we provide. That is our first impression of the hospital when they walk in the door. That's the first impression. And if that first impression is, I don't know what the hell I'm doing, that does not give us a very positive feeling, or doesn't make people confident that we're going to be doing the rest of our service very well if the front desk can't direct them, doesn't understand what they're saying, or can't provide them with the service they need. I think we really got to look at the front of the house to make sure that they are competent, that they're friendly, they smile, they greet people, and it also the way it's set up. We got the glass slides. You feel like you're going in some bodega in Newark or something like that. So I mean, that has to be more friendly, I think, too.
Yeah.
So when we look at the whole thing, when we look at doing some redesigning, or we look at sprucing up certain departments or whatever, I think we can't overlook the first impression that people get when they walk in the door. How are they being served? What does it feel like? Am I comfortable? Am I being made comfortable?
I agree, and we've recently talked about this multiple times. That was somebody that was filling in that day, you're correct. I completely agree with you. But we've talked about opening that window, because when you walk in, you have a window, and that was all like private and good for COVID and things, but we just want to have a desk similar to this at this point. We want that person to feel like they're engaging with you, like they're right there with you, but all that's going to, in both admissions, in the emergency department and in the front. But that's just going to take construction, which is going to take costs. So, but we've talked about that multiple times. We want to do that in the emergency department. We want to do that in the front as well. We want them to be this close to you so they feel like you're engaging with them and you're not in a little box window. And that is along with simple things like pre-registration a little bit better, so these people know a little bit better, and then having iPads or utilizing some things, devices like that, to make the process a little faster and a little easier for most people, and along with hopefully getting some volunteers out there to help people, all things we've discussed and we do have in the plans. But I agree, that first walk-in presentation is a first look for people. First impression's important.
You can't redo a first impression.
All right.
You get one chance for first impression.
I agree.
Let me say something too. I appreciate that, Bill. And we don't need to get our feelings hurt if we're not doing something like we need to do it, and that's what we're here for. All of our leadership is. And it's not individually criticizing folks. If we have something that's not functioning correctly, leadership has to take it, and I think David takes it. It's our fault. It wasn't that guy's fault. He wasn't trained. Okay, I don't think.
And we don't, and like we'll take ownership of anything that we do here at the hospital. I'm the CEO, so I take total ownership of that.
Yeah.
We got to continue to look at, of course, customer service. Could have been an isolated incident. You got one chance, but we know that we have customer service areas in not only in our front desk area, but all of our clinics, our EMS, everything that we look at. Customer service is not an event; it's a lifestyle.
That's right.
And you got to continue to work on that. With staff. And you can be trained, but then sometimes you may stumble, per
That's
se.
right.
But that's something that we'll look at. We take ownership of it. We hear it, and not only from you, I hear it from people all the time. So we try to make these different things to do, changes to do that. We talked about a redesign of the front. We've been talking about that as well. There's some new rural health capital outlay money coming up, and this is going to be on my report too. We're looking at a redesign of our ED. The ED area, for better customer service, point. Just to redesign that whole ED front as well. Because the ED area, that's what we use, most of our customers come in that area. So we're looking at a whole different redesign. But it's all about compassionate care. What can we do to remove the anxiety off that person that's coming through that door, to service. And we're not going to hit 100% all the time, but we would strive to hit 100%. And so we take, suggestions and we move on it. But that's something that we've been talking about.
Well, Mr. Bowen, we were talking just the other day about the fact that we have some possible capital improvement money that's coming down the pike at us, and I think we ought to think about sprucing up the front entrances for both the ED and the hospital. If we can just use some of that, what was it, $400 and some thousand dollars? I mean, that might be best used in some of those places to make us a little bit cleaner, a little brighter looking, and a little bit more friendly when people come in from those entrances.
And please, let's keep in mind our family members. We don't need family members waiting in the ER for 35, 40 minutes to go back with their loved one. We had a situation not too long ago, and I just think we need to keep in mind that a lot of time family members help. I realize it was the middle of shift change and they had gotten another patient, but TMH, Bay Medical, Sacred Heart, you don't sit in the waiting room, you go back with your loved one. Sometimes patients are confused unless you're doing chest compressions or it's an emergent situation. Then please tell your staff to remember to let family members back as soon as possible, because that takes a lot of stress off the staff and a lot of stress off that patient that is sitting there confused, especially when they've just been to the doctor's office and the history is not in the computer, the medications that have been changed, and there were things that needed to be collaborated and talked to with the doctor and conveyed, and you're sitting there waiting. So that should never happen. Somebody should let family member back as soon as possible. It's posted on the entryway in the ER, and it says we allow one family member back, so let's honor that.
What now, how many family members should we allow to go back?
Usually, I don't know what anybody else's policy is, but at TMH and Bay, it was one family member until they get stable, and then it's two family members.
I think that's
That's the policy. I've researched it all.
Yeah.
Is that generally?
That's the policy. It's at most facilities, and what Kristen's talking about, it was a lengthy thing, and it's since been summarized to make it a little easier. What she's talking about is the patient came in at shift change, and so the family member had to wait some time. I don't know, probably 30 minutes, I'm estimating roughly. But yeah, I think because it wasn't like a chest compression, we weren't coding that patient, anything like that, that the family member should be getting back sooner. Because even if we have that patient's, medications and stuff, like our system pulls medications that have been prescribed automatically even if they were prescribed earlier that day. But there's no reason that a family member can't be in there, because I'm going to want to be in there if I can. I'm with my son, my daughter, my spouse, my grandmother, all those things. So I'm going to read this out loud now, what we've since posted, just to try to make it a little clearer. We also discussed this yesterday in our med staff meeting with Dr. Conrad to make sure we're conveying it with the physicians, and I'm conveying it with all the nurses staff as well. So we just took that piece of paper we had out there that stated the same thing, tried to make it really brief and more precise. So it now reads, Weems Memorial Hospital promotes visitors in our emergency department to support patient care. The number of people welcomed at the bedside at any one time will be determined in collaboration with the patient, family, and interdisciplinary care team. The patient has the right to receive family members and visitors whom they designate and may withdraw or deny such consent at any time. And my nurses are instructed, one comes back unless you're doing, now obviously if it's interrupting care, we're not doing that.
Right.
But let's be true, 95% of the cases, you're not interrupting care. So my nurses, even though I'm not putting one here because on this piece of paper, because in those cases, people may say, oh, well, it says one. But the nurses are being re-educated that just let one person back. That person can be the advocate for the patient as long as it doesn't interfere with patient care when we ask the patient questions and such as that. But they can also be that designee for the family that can talk to the other family members and things like that. So it just kind of eases the whole situation, I think, for everybody.
I agree.
So
You know
that
what,
has
though?
been,
This is very good, because we're looking at stuff now we wouldn't looked at a couple of years ago. We had bigger, now we're getting down to some individual issues, and that's real good that we'll be able to do this.
yeah, and
Yeah,
honestly, I
that's
think sometimes that you get a patient back and you're like, okay, well, let's go ahead and get the IV and the blood work and the chest x-ray and things like that. But and then those admissions is hitting that, the staff, the family members hitting admissions, and they're not responsible for that. And then admissions is hitting the nurses, but if we're waiting on respiratory or we're waiting on lab, all those things just take time. So just that one person can be the designee for the patient, and I think that'll smooth a lot of things
And
out.
also, just for the board, and I know y'all have a problem with this, but if you see an issue with the hospital, contact me directly, right away.
That's a good
So we
thing.
can so I can take, actions you know, try to correct certain things, no matter how simple it is, you know. And so just for board members to know, I know I'm on speed dial, y'all got my number, you know, just call me, you know, so we can work through it.
I send you stuff all the time,
I
like,
know-
don't shoot the messenger, just somebody sent me
Yeah,
this, or I
and
saw
that's
on
good.
Facebook.
But that's
Don't shoot the
good, 'cause I-
messenger, but
you
I
know-
just
We
need
have
you
to
to
know.
know.
It's constructive criticism.
I tell people all the time, if I don't know, how can I correct it?
Yeah.
Like I say,
Correct.
people
Right
tell
now.
me, at church, I get, hey, Pastor Walker.
You're able to get it right
Yeah,
there.
you know, I
Right
need to
there.
talk to you about this. So at church, weekend, no matter, I mean, I get the calls. So if there is something that is happening within our hospital, EMS, of course, EMS will be out of here June 1st. But EMS right now, the clinics, you know, the hospital, let me know right away. You know, and it's okay because we need to address it. You know, that's all.
Yeah, I agree.
Generally, I'm in agreement with what has been said. However, I was going to make that comment that if something happens, and it happened even 2 or 3 days ago, why wait until a meeting? And the CEO does not know anything about it when we have access to him. Why, not only him, you. I don't understand that.
Well, I think-
If you want it, no, if you want it corrected immediately, then you get in touch with the person that and can handle that. You don't need to wait.
I'm glad we're having these, oh, I'm sorry, go ahead.
No.
You through? That was good. I'm glad we're having these discussions. We'd have never had them in the past. We'd had other things to do, and I guess I kind of feel good about it. So I would, you know, anything that needs to be taken care of right then, just call him. He's available and all. I hadn't had to do that much at all, but I do see improvements everywhere in customer service. When I go to the clinic, I go to Weems West here. Man, it's in and out mostly. You know, except I'm well when I walk in, and Suzette tells me what all's wrong with me. So, you know, every time I get my physical, I'm real healthy. I told her I'm healthy till I come here. Now let's get. Okay. We could dwell on this a long time, but I do appreciate it. Train. I believe in training, so that's what y'all are doing. Well, since I'm talking, I've got a couple of issues here as a chair I want to go over with everybody. Y'all got this handout here about the, if a hospital board member required to resign, there is a hospital board member. And what brought this up, there's a possibility that we might have some folks wanting to go to work full line or the hospital that's on the board. Okay? And if you see item 1, so I talked to Mr. Morone about it, and we called the county has a contracted attorney for personnel, and this is what he said. If you read it, is a member of the hospital board required to resign their position on the board if the individual applies for a position of employment with the hospital/line? No, nothing in the bylaws would require a board member to resign their board position to apply for a position of employment with hospital line. Can a member of the board always serve as an employee of a line? 2 members of the board, this is in the 5th Amendment, George Weems Hospital Governing Bylaws. 2 members of the board may be employed by hospital line. However, any board member who's also an employee of hospital/line is not permitted to vote on any item that may involve employee salaries, benefits, working conditions, hospital work rules, or policies. So, you know, read that any way you want to. Basically, you wouldn't be able to vote on much at all. It is our recommendation that any employee of hospital line that also serves as a board member be required to resign from the board to prevent potential conflicts and because employees limited voting power on the board. So that's what it says there. That's from the attorney. I'm not going to go much more than that. There it is. Now, next thing I'd like to discuss. Did y'all get this in the email? You've got a copy of your governing bylaws. Did y'all get it? You get it? Everybody get it? A couple things I'm going to go over right quick. we got to make sure we do. I highlighted on mine, y'all give me a second here. You know that the purchaser make comments, capital page 3.
Page 3.
Yeah, let me go to 2 first. I've been trying to get to 2 here. Okay. Okay, one thing, page 2, item K. One thing we're required to do is periodically review and appraise the performance of the CEO. So we've done that, and the next meeting we will cover it, okay? I don't know if everybody did it, it's up to you if you want to do it or not, but it says this board will periodically review and appraise the performance of the CEO. Any questions on that?
Yeah, where does that go to after you do the appraisal?
Well,
Who reviews that?
I'm sure I don't know.
Well, wasn't it part of the
I don't
Alliant?
know, it don't say where.
Well, the Alliant online appraisal, I mean, that considers
That's
considered
Alliance
appraisal, right?
appraisal, right?
Well, we could use that, obviously,
Well, we,
as a means to,
we've already, we've
Done it.
done it.
yeah,
Yeah.
yeah.
So we've done it.
But we would need the results from Alliant then.
Yeah, Alliant, look at both of them, and
Yeah.
then the county, I would advise the county what we come up with there. I mean, I think that's the right thing to do, whether it says, well, what do you do with it? So that's what I'm gonna do with it when we get through with it. So page 3, we cannot, things we can't do in a couple of, is make capital improvements exceeding 50,000 without prior county approval. Now, I would suppose we're gonna run into this when we start with the pharmacy, right? So we'll have to, whatever that is right there. And of course, we've gotta operate the budget within a budget
Well,
approved.
can I ask you a question at that point?
Yeah, I probably can't answer it, but I'll try to find one. I mean, I'll be honest with you. You know, we're in muddy territory right here.
If you set a goal or say, okay, your target is $250,000, $250,000, okay? You've got your architectural fees being done pro bono. You still have to hire CEI, develop a contract. You then have to get the construction people, put something out there for construction.
Sure.
To bid it out. Now you've got the ability to sort of zero in on time frame and cost. The issue is that at this point in time, when do we have to go to the county commission? And as I see, you don't have to go until you get to the point that you have to select somebody to do the construction.
I don't think so. I don't think so. We gotta look at that $50,000.
Well, to answer your question, I think on my side, that we did get the approval to move forward with the pharmacy
That was it, right.
on our last BOCC meeting. So let's move forward, and when we get to that point, like you said, we should be giving the BOCC, we have identified a contractor, here's the amount that it's gonna cost us, and here's the time frame. Now, if it has an overrun beyond the time or the cost, then I think we have to go back. But if we get an approval to do that time and that cost, right, we move forward.
Well, yes and no. Because here is something that I'm having an issue with and need to get it resolved. And that is, not everybody does CEI work for a minor construction program like this.
What is CEI? I'm sorry.
Construction, engineering, and inspection.
Okay.
In
I
other
got you.
words, they take the plans that the architect comes up with,
Right.
and we agree to, and then they have to effectuate that.
Right.
And
okay.
the county currently uses
Dewberry.
Dewberry and Associates to do most of their CEI on road projects.
Right.
And I did go ask for where was the one for the armory, and basically nothing's been obtained so far. So if you do it this way, you don't have to go out and bid, which I've sort of don't think that's fair. I think you probably got to give everybody an opportunity to look at the CEI work. Now, the CEI is the key because they are the interface between the board and the project. And the CEI, Marvin Heyman, who is doing the architectural work pro bono, he has offered to do the CEI work, which now he takes his plans and he has it built. But that comes at a cost.
Sure.
And that cost can be below $50,000. Are we allowed
Yeah.
to go do that type of contract
You are.
without having to go out?
You are, because it's under $50,000, and so we are allowed to make that appointment for him to be the CEI. And so Marvin, just so y'all don't know Marvin, he's the architect that's doing the pro bono work. If we select him as the CEI, he will coordinate with Craig Gibson, our plant operations person, and then also make presentations to the board with that. But we can, if anything under $50,000, the board, the hospital board can make that decision. Anything over $50,000, then we take that to the county commission.
Now, one thing that I would ask, I know Marvin very well, great guy, okay? Used to play tennis with him over there.
Mhm.
He built his own tennis court. But anyway, the question I have though, how competitive is the price? I have no idea what the price. So, another thing too, when you bid something out, you don't have to take the lowest bidder. I want quality for what we get to, somebody with personal involvement with this. So when you bid it out, at least you get a ballpark of what it might be, unless somebody, Craig, would you know what it should cost for the CEI? I mean, see, I don't know. I don't, that's what we're.
Yeah, it's been a while since I've had to deal with that.
Do what?
It's been a while since I've had to
Yeah,
deal with that.
okay.
Yeah.
So, I don't know, it's a little dilemma there, and I don't know what to tell you.
That's a dilemma that I'm going through right now.
Well, Mr. Barry, can we get Marvin to give us a number?
Yes, we
A
can.
proposal.
Yes, we
A
can.
proposal, it'll be a
But
proposal.
once we decide, you don't do that until such time you've got the architectural work
Okay.
completed and know where you're going.
Well,
And
once
that's
he
your
completes
roadmap.
the architectural work, he'll know where he's going.
That's exactly right.
Well,
And that's why I like the
That was very
idea of having
Yeah.
the same person doing it.
Oh, yeah, he's gonna take a personal commitment to it, you know.
But you're getting a 2-for-1 there. You're getting the architect for free and then CEI at cost, so you're getting, both projects or both performances.
So it's the board's belief that they don't, if the fee for the CEI is not greater than $50,000, we don't have to go to that county commission, that we can do that ourselves.
Yeah, we do it all the
We do it all
time.
the time.
Okay.
Just tell Marvin that's not the number that he needs to come in at.
And
Okay.
one good thing about that, I know we don't jump ahead of what, because the pharmacy was on the agenda. One good thing about that, you have the architect doing the plans, and then if the architect can serve as the CI, they're familiar with the plans for that. And so it'll make our life a lot easier as we move on, begin to outline
Yeah.
the pharmacy there. So, if it comes under 50,000, we review it, bring it to the board, take a look at it, and move forward.
Okay, that's good. Glad we're covering this. Okay. Look at 3.3 qualifications. Right in the middle there. Board members shall not be employed by investors or associated with any other organization in competition or otherwise possessing a conflict of interest with the hospital. Hospitals under the age of 21 are ineligible to serve on the board. No more than 2 employees doing business in the hospital shall serve. So I guess if somebody becomes employed with a competitor, then
Is in another hospital?
That's exactly what I was going to ask, Ms. Dolores.
do what?
I was going to ask the same thing she just asked, as in another hospital.
Yeah, it'd be another hospital.
That's a competition,
And
yeah.
I don't know what our competitor would be, we'd have to, but I think it'd be good for a board member if they become employed. I don't have a big personal problem, but I know what this says right now, so this will be up if somebody did become employed with another hospital. I think that's up to the county commission, not us. It's their board, okay? That's the way I look at it. Notify them, and whatever they say, I think we're happy with it.
And what item is that?
3.3 on page 3.
3.3 on page 3, right in the middle there. Board members shall not even. Okay, next item. The terms of board members. 3-.5, board members shall serve terms of 3 years. Terms will be staggered, possibly multiple, expiring the same year, that's not it. There are no term limits, and board members may serve any number of consecutive terms. Okay. Now look on the next page, page 4, 3.6, the last sentence. Board members whose term have expired may continue serving until they are either reappointed or their successors are chosen. Does that mean we need to advise the county when a board member hits the 3 months? I want to ask y'all what y'all think.
3 years?
3 years. It's up to them. I mean, they can continue. My thing is, I think we should do that. We want everything at board. So did somebody get me any information on the board members for over 3 years?
I-
I mean, I don't keep up with the dates there. I don't know.
That's the problem. Nobody does.
Well, we know when.
Have you been here 3 years?
David,
No. Soon, though.
Yeah, so what happened with our hospital board, first of all, it was so hard to get people to volunteer on the hospital board. And normally what would happen, if somebody, was serving, 3 years up, they continue to still serve. But we also, sometimes we send, Mike Marone a list of our board members. We hadn't did that lately, but we can always do that. But Heather, at one time, kept up with the different board members' expiration dates and things like that. But like I said, usually when a board member's term expires, you commission keep them on there because it was so hard to get people to be a part of this board. Really.
well, it's, their term expires, that's up to the commission
Yeah.
if they want to put somebody else in, okay? I guess if the commission stays silent on it, that means, but I'm trying to figure out what to do.
Yeah, but we can
Somebody's
send,
got to bring it up to the commission.
I'm going to I'll talk to Mr. Marone about it, see
Yeah.
what he thinks.
Because this is a conversation we had 2 or 3 years ago when we were writing these things.
I know, I agree. So, does Heather have the dates?
but we have a list of the dates that people was appointed.
She does?
Yeah, we have a list of that.
Well, I'm gonna look at it, and then, the question I would ask, anybody with the 3 years, are you still interested in serving?
Do we have
You
some?
want to keep serving?
What are the dates? I can't,
Well, I'm gonna find out the dates.
Well, what we'll do, we'll see.
Everybody knows approximately how
Right.
long they've been on the board.
I don't
Right,
know.
I would hope so.
can't-
You
I
don't?
don't
I
know.
I don't.
I don't know a year
I know
from
about
today
3.
almost.
Huh?
I'm about 3.
But
So
we
it's
have,
time for you to go?
Yeah.
well, I tell you what, we have
Yeah.
just for clarification, you all,
You should have been going already.
You're the only one that's probably not.
I've only been,
commissioner's gonna
yeah,
keep
April
me
was
on
a
here.
year for
hey,
me.
just
I've only been here a year.
for clarification, we have a list. We have a list, we can get that from Heather to get the crystal sent out to y'all. Heather's out today, but we have a list of every board member and the times that they were appointed.
Let's,
So, and what I do,
let's make this simple.
what I do, simple, I'll send it out to all the board members, and Duffy, you can talk to Mr. Marone about it when you get that sheet. But I'll make sure matter of fact, I'll send it out, I'll print it out for you all. If you want to print out, I'll give you a printout of it. But I had a list.
Who's on the board that's from the hospital? Who's the non-voting members?
Dr. Conrad,
Conrad, yeah.
Dr. Conrad, the medical director, the CEO is a part of the board, usually the CFO would be part of the
court,
board
right?
too.
In
And so,
court.
we're non-voting members here. Everybody, all the voting members are you all.
Yeah, but there's two on the board that are,
Michael.
well, the way I read this clause, there's 2 of them that are of the 9 that are non-voting. Now, who is that?
Okay, you have the medical director, you have the CEO, which is part of the board, and then, usually the CFO is part of the board as well, but the medical director is part of the board, Dr. Conrad, but he's a non-voting member. I'm a non-voting member. CFO is a non-voting member.
Okay, that's 2.
Yeah.
There's 7 more. Where are the other 7?
7?
Seven.
Two from 9 is 7, right? Did I miss
I don't
something?
get
Where I
that.
went to
I don't
school it is,
understand.
but
Okay, so what you have each commissioner, let me just explain this. Each commissioner has a vote, okay? And then
7 are voting, 2 are not.
we also
Two
have,
at large.
yeah, we have 2 at large, so that's 7,
What is 7?
right?
But the board says 9.
Yeah, okay.
Yeah, that's you, me, her.
Yeah.
That's the 7, and 2 that are non-voting, that's 9.
Dr. Conrad, myself, is non-voting. Dr. Conrad and myself is non-voting, that's 2. And then you all up there, we have 1 position that is not filled, that's Commissioner Jones' seat. That's the only one that's not
oh, so
appointed.
we're missing a board member.
Yeah,
So we are missing
We're
someone.
missing
member.
1.
you're just missing 1,
1 voting member.
Okay, and
yeah. We have 1 voting
so
member.
all these, we're all voting members,
Yes.
right?
Yes,
Yes.
yes.
Okay. Now, what districts do we represent?
Okay, you represent,
2.
2,
I'm 4.
4,
I am
at large.
at large.
Yeah, one of y'all at large, I
Me.
think Murders
I think
represent
Ms. Murdis, and I'm 4.
4, 3. Anyway, we have a list of all
So
that.
how do the at-large members get picked?
They get picked, usually a commissioner will recommend a member to be at large.
When was the last time we had a recommendation?
Well, Bill,
Bill
let me
probably
tell you
the latest
let me
one.
tell you what happened with that. I'll tell you.
Smokey,
Duffy was a-
Smokey,
Duffy
who
was
was
Let me
a
go into that a little
Board of
bit.
County Commissioner
Okay,
guy.
let me go into that a little bit. Let's clear it all up. And then we're gonna move on.
Yeah, because we got
Yeah,
a
Yeah,
long
because
agenda.
me and Mr. Lewis gonna get hungry.
We got a long agenda. We got-
Hold on a minute.
we got
You
this-
bring a sandwich?
I am, I was an at-large several years. And, the commission asked me if I would mind not staying at-large, go with a district. That way they could select somebody from anywhere in the county and get another board member. And that's how I become at-large, okay? I mean,
So you were at large at one time.
yeah, which, it don't matter to me.
Are you at large now?
No, I'm not.
Okay.
No, I'm not.
Yeah, he
So,
was
I
at,
mean,
he was
that
at
don't
large when
matter.
we had Doug
We're
Kramer,
getting the weeds here.
the former hospital board chairman that passed away. And so,
Yeah.
Duffy
Reel it in.
district he was appointed as appointed position as he took over the chairman at that time.
Point. Mr. Morone, I'm glad you're here.
Uh-oh.
No, real simple,
Ruh-roh.
real simple.
But we gotta move
Okay,
on,
I just
y'all.
want to ask you, I've reviewed fine tuning this Fifth Amendment of the governing bylaws, make sure we're doing everything perfect, okay? And the board members, I don't know how long my 3-year term is. I don't know when it started, but Heather has the dates, okay? As it stands right now, I think all the board members would want to be fine with the reappointment.
Okay.
That's what everybody said. So how about we give you them dates? And then I would guess the board, they need to vote?
Yes,
then?
to reappoint
So-
everyone.
So, and we'll keep up with this better and give you the dates, and everybody would, and I'm gonna throw in something, I think we have an excellent board here. I would hate to see something happen to it. Even you, John, you're excellent. I had to throw that out there. Every now and then, you gotta throw that out there. But,
Showing your true colors.
no, I'm not. I think, man, you're smart. Anyway, you think that would be okay?
That's fine.
Good.
Not a
Let's
problem
go.
at all.
Move on. That's
Or
it.
you could look at it like the mafia, once you're in, you can't get out. How
That's
about that?
correct. That's correct.
That works?
You know too
I'm
much.
good. Let's move on.
I'll send it to the board, we got everybody.
That's it.
Sounds
That's
good.
it. Okay.
You still didn't answer. How did the at-large positions get picked?
What we could do is, we could look through the minutes and then build a history as to how that came about and get.
Because there's 2 at large. Somebody, all right.
Who's the 2 at large?
All right, I'm at large.
One,
We-
okay.
And the way it happened was Duffy was at large. I don't know how he got at large, but he was at large.
Yeah.
And then I came and said I wanted to, interest in the board, to Weems, and I said.
Somebody was already
Right.
in
So-
there.
So what they did was, they moved Duffy over onto a board member on a location, and in order to put me on the board, they put me on at large. And Smokey, who was a Board of County Commissioners, commissioner, was the one that made the recommendation to move me onto the board.
Recommendation and
So-
then vote like that. So that's it.
That
Does that
one.
answer your question?
Yeah, and then
What's the other one?
Commissioner
I don't
Lockley
have
put,
Oh, that's
Croom.
the missing, I think that's the missing board member,
let me
right?
just- Okay, Commissioner Lockley appointed Ms. Croom
Appointed me.
as an at-large member of the
At
board.
large?
Yes. Yes.
So she's not from that district, she's from at large.
She's at large. Murders represent the
So we
district.
have two at large up here.
Yeah.
And we don't have all the districts represented.
District 1 is the only district we don't have represented.
That
Okay?
answers it.
Okay, there we go. Let's move on. Thank you. One more thing. One more thing. When two or more board members are in a meeting concerning the hospital, it's got to be in the sunshine law. That's covered. So two or more. One don't be nothing. So, your meetings, all the meetings we have to post them, and that includes pharmacy meetings too. So, gonna need to, I think the posting is a reasonable time, we can get it posted right on the hospital thing right there. But now during that meeting, the only thing you can discuss is what would be the finance committee, would be finance, and would be the,
Pharmacy.
Pharmacy care about. So I
Right.
want to make sure clear on that, so nobody says nothing.
And John will give an update.
We're gonna move up. I'm through with my stuff. Next thing,
Oh, wait, let me, Duffy, because what we didn't do, you know. I
the
didn't-
employee, I'm
Yeah,
sorry. I'm
Employee of the
sorry.
month. The employee of the month, I don't have it on the agenda. The employee of the month is Miss Lily Mills. Lily Mills been with the hospital for 54 years.
She has.
54 years. She works in the dietary department at the hospital. We're so blessed to have her. She worked in a lot of different departments. And that's why when we say we look at our staff as a whole, you know, the dietary department is just as important as any other department. Because when AHCA, the Agency for Healthcare Administration, comes in, one of the areas that they monitor very tightly is dietary. And so, but Miss Lily Mills, you know, we're so happy that she's working with the hospital for 54 years without retirement. You know, you think about that. Somebody invested their life in this community. And so we're going to recognize her today. And then Hospital Week is coming up, and we may want to do something special for her.
I
You know,
agree.
54 years there.
I had a patient reach out not too long ago that was admitted, and they bragged and bragged and bragged and bragged about the food. And some people think that's not a big deal, but it is. It's huge. And that was because Miss Lily and her team, Miss Mary Brown. So
Yeah. It is.
Somebody bragged
Super.
about hospital food?
they
We're
they
doing
did.
a great job.
She really
We're doing a
did.
great
She
job
went on
now.
and on about the hospital food. So I think
That's-
that's wonderful.
that's-
So kudos to Miss Lily and Miss Mary Brown.
That's a
That's
valuable
all.
person right there. Okay, thank you. How long has she been?
54 years.
54 years.
I think if some of us at the hospital, we need to go by and thank her for good work. Personally, I'm talking about the board. I mean,
Yeah, I think
if
that'd be
you're
good.
there, I think it'd be a good idea to make an effort to go by and say hello. And I believe our Alliant representative might want to tell her how much it means to everybody, you know, who's come up to board meeting today. So, okay, I'm going to skip. Colleen is here. Colleen Zester is here with the foundation, and let's put them up because she's got to go somewhere and she don't want to sit through this other stuff.
Sorry, just multitasking. Hi, everybody. Just a quick update. Just again, keeping to our 3 published priorities, right? The first one, comfort and compassionate care. We've been doing a lot of things since our last meeting, partnering with a great team at the hospital. We have Hospital Week is coming up. Thanks to everybody who's been helping with that. Thanks to some of the businesses in our community. Bill actually has a handout. I sent you all an email about everything that we're doing Monday through Friday of that week. If you can join us for any one of those days, it'd be great to have you. We're basically going to be celebrating the hospital team that's doing such a great job. And then the other thing I wanted to still need to confirm the date, I think, Mr. Walker, I'm not sure, but the hospice suite, right?
Oh, yeah.
That's being redone, and we're still planning for a ribbon cutting. I think we're now shooting for June.
Yes.
So we'll let you know when that date is set, because it would also be great to have you all join us for that. Tapping into a lot of our donors for Hospital Week, so again, we'll give a shout out to everybody once that occurs. Then the other thing I'll just mention quickly is we have started to publish our annual event, Rising Tide Lifts All Boats, or as somebody said to us last night, whatever floats your boat. We have pushed communication out to our previous donors, attendees, sponsors, and we've already started to receive, people are purchasing tickets. We've gotten some nice sponsors, people raising their hands to volunteer. It's again November 14th. This year it's actually a Saturday. It's at the Apalachicola Yacht Club. We've identified our musicians, starting to look for donations. We are going to do a silent auction this year. On site, so more to come on that, but hope you all will come and join us. It
When
promises
is
to be
that,
another.
Colleen? November 14th?
November
14th.
14th, it's a
I
Saturday.
know there'll be notices. I want to go and check my
Yes,
calendar.
check
That
your
was-
mailbox, sir.
that was fun.
You have an invitation link. And then, other than that, we're just continuing to, on our donor drive and engage sponsors and interested parties in the community. I think Mr. Boland can attest to, we're really starting to build some really important bridges. When Bill and I are out in the community, we often see members of the board, Kristen and her husband. People are interested in what's happening at the hospital, and their, the confidence is on the rise, which is fantastic. So to Bill's point, first interaction, first impression at the hospital is really important. People care about what the building looks like, but they're going there now because they believe in the care. So everything the team's doing is so very important, and people want to get involved. So thanks to everybody that, everything that everybody's doing. I don't think I have any other
Yeah,
updates.
and I just want to just highlight this too. First of all, I want to take a moment to recognize our hospital planning committee. Their work is more than event planning. It's directly supports employee engagement, culture, and retention. But specifically, we want to thank Colleen.
Yes.
Because she really
She does an amazing
have
job. She
taken-
really does.
She really have taken the load.
An amazing job.
She really taken the load off our staff, because usually the staff are the one that's planning a lot of stuff here. But Colleen just jumped in and kind of like helped organize a whole lot of stuff, and staff, the anxiety off them is good. But I want to just thank Colleen,
Well, thank you.
for the work that
Me
she's
too.
doing
Thank
here.
you.
Yeah, I agree. I want to piggyback that and just say, usually Hospital Week is planned by hospital staff, and it's meant to celebrate hospital staff.
Correct,
So-
not stress you out.
Yeah, so personally, myself being one of the ones that leads this,
Yes. it's a
really
huge stress
appreciate
off your
Colleen,
head.
because we want to be able to enjoy the week, and we're
That's
still,
right.
working with her.
Of
But we
course.
really appreciate you and all she's done. She's coming to these meetings with us, she's doing the planning on the backside, she's organizing it. Been a huge blessing, so we appreciate you.
Thank you so
It's
much,
normally like,
Colleen.
I'll take you to dinner, but you got to clean the kitchen up.
Yeah, yeah.
You don't want to do that.
Right.
Happy to do it.
And when we say hospital week, we also talk about our clinics and EMS. So
Yes.
it's every department under that umbrella. But make sure you all come out and help fellowship with the staff that week. Here's the brochure, should be in your binders as well. But I just want to recognize Colleen, the work that she's doing for us, because she's made life a lot easier this year.
Well, happy to do it. Thank you. Thank you. And then I would just, again, shout out anything, you get any questions about the gala that's on November 14th, anybody who, wants to make any kind of donation, whether it's a donation to the silent auction, they want to become part of the planning team, whatever, please send them my way. The more the merrier.
What are the tables? You want,
The one that is on the website and on our Facebook page is the active one. I don't believe it's the same one as last year. But I will send it out to everybody, okay?
Colleen, is on the website the tables, how do you want to sell the tables, like a six-person?
So,
Have you got gold bonds?
last year we evolved to a different model. So if you recall, the first year we did it at the Armory and it was very formal and you could purchase
Right.
tables and all of that. Last year, we changed the model and that's the model that we're following again this year because it was far more successful. And that is at a certain level of sponsorship, you are provided a dedicated, reserved table. There are individual tickets that are available, and those are really first come, first served seating. If you were at the event last year, you recall it wasn't really a plated dinner, it was more of grazing and
Yes.
small plates.
I
So
like
we're
that.
going with that again.
That's great.
From both a guest experience and a revenue perspective, it just works out better. So to answer your question, If you're at a sponsorship level, reserve seats, yes. So there are options for getting reserve seats or just first come, first served. And that's pretty well spelled out on the ticketing site. If
Okay.
you have questions, let me know.
It was a wonderful event. We're super excited this
Yeah,
year.
thank
It was
you.
an awesome event. Thank you for your hard work.
Yeah, thank you. That's it.
Who's the band?
So we're having a jazz musician who will
Is
play
that
the
chemistry?
piano for the first hour from 6 to 7.
Really?
And then from 7 to 10:30, we have a group called Chemistry who, when they
They played for my birthday.
Yeah,
and they
I
were
re-
amazing.
yeah,
Yeah,
yeah.
they played for my birthday. They were
Yeah.
amazing.
They're a band out of Valdosta,
Your
Georgia.
60th birthday, I'm sorry.
And that makes you 180, Duffy.
That's all I have. Thank you.
Good comeback.
I couldn't help that.
Mr. Chairman, I got a question, if you don't mind.
Sure,
It's about, I'm gonna backtrack a second.
okay.
Who is Carson and Atkins? Is that our attorneys or something?
That's the county labor attorney. The county contracts with a labor attorney.
And who requested this opinion from him?
I did.
Okay. Did we pass that, did we discuss this before?
No,
Okay, thank you.
it came up. I got an answer to it. You know, that's something I feel like I should do. I don't think this discussion, I thought that was too important. I talked to Mr. Morone about it and what he would advise on it, because I've been going through these to make sure that we're doing what the body, we're supposed to do here. And he right away said, let's talk to the labor attorney. So that's the real event. Okay, next item. And I thank y'all. Bill, you got anything else to say about you're on here, the agenda for the foundation?
No, no,
Your
not for the
name is here.
foundation.
Good, thank you. Next item is Dr. Conrad. I don't believe he's here, but David, you
Courtney can
talk about this?
No, he just finished a 24-hour shift this morning, but we also had med staff meeting yesterday, and he didn't have any updates, so I think everything's going smooth. I think transition with the physicians to the hospital has been good, and everything's on track as far as I know.
Okay, we got radiology staff approvals, I guess, Dr. Conrad.
We do.
approved them.
Yes, sir, I have that here. So yesterday during the med staff meeting, they approved these. The board members presented a list of the providers for privilege approval, and we just need action from the board for this approval. You should all have that list of providers for the radiology.
And we're still with the old radiology group, but we also have the new radiology group that we're ramping on board. So once we
turn over?
well, as soon as the interfaces work,
Okay.
so we may be looking at another month, but then we have to give a 60-day contract out. But
Okay.
we want to make sure everything flows first before we do that. So we just need this approval so we can continue to move the process on.
So the Vesta ones are the ones that we currently have that we're getting rid of, and Irving are the new radiologists that will read for us in this transition.
So we need to know, Dr. Conrad's already
Yes, sir, Dr. Conrad and Dr. Hart with proxy, yes, sir.
recommended to us to vote on this.
Yes,
correct?
sir, yes, sir. We just need board approval on this.
Okay, do I have a motion to approve the reappointments, initial appointments, and for radiology?
Motion.
Second.
Any discussion? All in favor? Aye.
Aye.
All opposed? Passed, okay. Clinical service report, Ms. Alford.
All right, I'm going to start with the Omnicell towers. I don't know if you guys remember that.
Pharmacy medication, is this form here? This quote there.
You mind handing them that? Which one is one?
You want
Yeah, there should be more than enough.
Y'all should have this in the package.
They don't have all-
Is this in the package here?
Melanie is passing something out also.
Yeah, this is additional information that was provided. I was gonna, Cindy is the Omnicell rep, and she provided me with that information, so that's just a little more information. It'll show you some diagrams of what these towers are if you're not familiar with them, and give you a little more information on that.
Thank you very much.
So I'm just gonna kind of do a little brief summary on that. I know we got that rural hospital capital improvement grant money last year for Omnicell, and we designated some of this to go towards the Omnicell tower. The Omnicell is the med dispensing towers that are used in both our pharmacies. We have a 2-tower unit in our emergency department and a 3-tower unit in our main pharmacy. They also have return bins that open whenever we return a med, and we have to sign in, and then they lock behind it. Then they also have what we call a flex lock, which is a lock that locks on the refrigerator for where we store our insulins, our Ativans, all those refrigerated meds that have to be signed out and locked. So this quote includes all of those things along with the server upgrade and such. So you will probably the first page that you may see may be the total of the $44,621. That is the remote access license you'll see on there. That is allowing Wes as our pharmacist, and myself too, because I have to go in when we need new users or users are locked out and reset these users. That allows Wes and I to have remote access, to be able to access that from our houses. So he can approve meds when their patients are admitted. He logs in and approves those meds, so he sends them over to the Omnicell tower so that the nurses can pull those meds. And then I generally only use remote access to unlock the nurses or the staff that's going to pull those meds. So that's what you see for that $785.70 there. And then the next one is the OC Server Windows 2025. This is a one-time charge that will serve over the life of these, which is a 10-year span there. So this is just the server window that we have to upgrade. We're currently running on an expired server, so this is a big need. Now, when you look further in the quote to the actual towers, you'll see there is a Med 3-cell cabinet. That is the one that's in the main pharmacy, the larger of them. You'll see that one first. That's the larger of them. That's the $61,000 you'll see. And then under that, and stop me if you have any questions at any time. And then under that, you'll see the XT external return bin. That is a wired cable mounted bin that sits to the side of the Omnicell tower. So if I pull Tylenol and the patient refuses it, I have to go back and return it. But you have to log that, and then it has to go back into that locked box. And then the pharmacy pulls those, goes against discrepancies and things, and then returns them back to the bin. So we have to have that in both the ED and the main pharmacy. So this is the main pharmacy. And then that premium Win 10 package, that provides you with 10 years of useful life for the cabinet.
Where's these numbers coming from?
You should have gotten this from Crystal prior to this. No, it's this one with the green on it.
Court, are we replacing both Omnicells? Or
Yes, they're
Okay,
both
okay,
expired.
Good, good.
Our service contracts are expired on
Okay,
these
good.
things. Yeah.
I don't have
Where did you find this?
right here. Yeah, with the blue one. Look at your packet. You're off. You don't have the book. Look.
There's always one problem child in every group. Hey, it's usually me. I'm glad it's you.
I'm gonna start, what do you call it, zooming in. I can turn y'all off then, I don't have to be listening to all this.
No. Gotta have you.
Anyway, I just gave
Did
you.
you find it?
I gave it to you.
It's right there in the
You
green.
can use the one I just gave you.
Here's the green one.
Oh, use the one you gave me, but you
Yeah.
didn't find it in here.
That's a blue one. Mine's a blue one.
Yeah, he's good, yeah.
I didn't really look too much.
Blue one in our book.
So that premium Win 10 package you see provides that 10 years of useful life for the contract to cover the software as well. And then that Flex Lock you see again is, that's an annual, that's the lock that goes on the little mini refrigerators where our stored cold medications that have to be controlled, like insulin and such are. And that is on each of the units as well. So you'll see that the 3 unit is for, again, the main pharmacy. The 2 unit is for the emergency department. And so these together have that total cost.
So Courtney, this is replacing a system we already have, right?
That's correct.
And the system that we have is outdated,
It's
And
outdated
not under
and,
warranty and not,
correct,
So-
our service agreement
Yeah.
on that, if it broke right now, we don't have a
Right.
service agreement on it.
And
We
it's a
have to
dinosaur.
expire this, yeah.
So-
So you feel real good about this, Courtney?
Yes, so I will support that too by saying that, I've got a whole folder on this, but we have information, I reached out to our pharmacist and said, Wes, what are the top providers for these med storage units you would like? And he told me, and he gave me a list, and we got quotes from most of those. And then I reached out to our Alliant manager, the purchasing management, and they gave me a list too, and Glenda reached out to all these people, and I will say that only one of, and Omnicell is the only one on Wes's list and this list from our
Okay.
purchasing agreement. It's the only one that both of these things offer. And all of these others, only one other on our purchasing agreement even does what we need, because we have to have where the nurses will sign in. They'll have their name, their password, and once they sign in once, they'll be able to sign in with a fingerprint. That's an option we don't have now, but that's gonna be super nice for nurses. You just put your fingerprint in there, and then you're in there, you're logged in. You pull those meds, you go to the patient, you've got all their meds there, Wes remotely accesses or comes in and approves them, so when you pull their name, you see everything that's ordered. You can't pull it if it's been given in, the 4-hour time frame it's ordered, such as that. And then it dispenses all of these meds for you. They're all in locked drawers that pull out, as you'll see on that display, and each one of those drawers has multiple units that are also locked in there. So it's the only way to dispense medications. Kristen knows more about this kind of stuff, and there's lots of other providers and services that are offered from larger facilities, but this is what we currently have, it's what we've had, we're all familiar with it, and it's the only one on both of those lists of services that Wes and are purchasing. So
Was it
I feel
fairly-
good about this.
was it fairly competitively priced against the other ones that you
It
looked at?
was a little bit more than a couple of the other ones, but I mean, I feel confident with it, Wes feels confident with it, and again, it has that IT, there's a IT, Cindy, who sells this, of course, but she was saying that IT aspect is something that not most other providers, and she will offer with this, with that service window. So I don't really understand the whole IT thing, but she said it's protected for the 10 years of the contract, so.
And this is just for the hospital, right?
This is just for the hospital, yes, so this is what.
Will you need to train your nurses, or they?
They're trained, they already know.
They're trained, they know it, and they'll send.
We're already there then,
Yes, sir,
right?
they're familiar with it.
Yeah, we have this, and Omnicell will send somebody just to do like the fingerprint training.
Right.
But
Okay.
it'll be a very smooth transition if we just move forward with this.
Okay.
We have to have it, there's really no choice.
Yeah, no, I mean, honestly, if it breaks down now,
I agree.
we're in a
I
pickle,
agree, we
so.
have to have it.
Mr. Bowling, you've reviewed this, correct? Okay.
Thanks, Court, for your research on that.
What do we need
Sure.
to do? It's going to require a board vote?
Yes, it is, and we do have that grant money, so that's gonna
Yeah.
cover.
Money?
Yeah, this is paid for out of the grant money we put in like a year ago forward, but we wanted to make sure that we got the one that can have the updates ready this time
Good
of
work.
year.
Good work.
And so, which is good. If not, things that we buy here, if it's capital outlay, usually we have to go to the hospital trust fund to get that money. And so these grants allow us to keep the trust fund money not touched. And so this is something that we'll take out of that capital outlay funding that we put in for last year. for this.
This is grant
But
funded?
being this is over $50,000
We
contract,
approve.
we still have to pass it by BOCC,
Yeah,
correct?
yeah. So the first step, you approve it, then
We approve it, then
take
they-
to
Do I have a
BOCC.
motion to approve?
Can I
Motion.
ask a question?
Okay.
John Bear has a
Does
question.
does it interface in any way or have any effect on the pharmacy that we're talking about in care?
No, sir, because this will be just
No.
for patient dispensed medications. So we won't be, you won't be using this anywhere in the pharmacy that
No,
we.
this is for staff, this is for your nurses, this
Yeah,
has
if-
nothing to do with pharmacy.
Right, you check into the emergency room and you need an ibuprofen, this is how we get it. This is the only way, so we can document it. It goes back into the charting system of the nurses. This is the only way. So this won't have anything to do with the Carabel Pharmacy, no, sir.
And it's covered by the grant of which we already assured?
Yeah,
Yes,
yeah.
sir.
It may come up, I mean, we may be over maybe 5,000, 10,000, something like that. And then we
5 and
decide-
10's a big difference there, Walker.
Well, what we may be over, Courtney?
Hold on, I'll look right here, I got the grant.
Because we want to make sure we get the best. And so what'll happen is that we will, whatever the grant doesn't cover, we go to the county commission, say, hey, we want to get X amount out of the trust fund for it.
Okay.
And so with the grant paying 95% of the costs, I'm thinking, you know, we need to get 5% out of the healthcare trust fund. I think we should be able to get that. Because if not, we have to go to county commission for all of the money for that.
So the grant covers $245,000. If you look at that total on the package, it's 216,836.81, but you actually subtract that 10,080 because that's the life that's provided for the useful life for the cabinet for 10 years, and that's something that none of the other ones offered. But what you do is that's actually a billed fee that you're going to send that $42 a month over the 10 years, because Omnicell does that so they don't have to reach out for a PO every month for 10 years.
Yeah, that makes
So if you take that 216,836.81, you're subtracting $10,000 right there, so that's 206, and then you're gonna have to add in that $44,000, so you're looking at probably roughly, what's that, 260-ish, so you're looking at about 15,000 more dollars that it's gonna cost us more than the grant, and that's for the 10 years of the service, and then you're gonna have to pay that $10,000 over 10 years as well.
So we're good
Does that
for
make
10
sense?
years.
We're good for 10
We're good for
years,
10
yes. The only thing
essentially.
that you should have to pay is that $42 a month for 10 years.
Yeah.
And that has a maintenance fee in it already,
Yes, sir, so that includes the maintenance and such, yes, sir.
and upgrades to the software,
Yes, sir, so that covers us for the 10 years of the software.
and the contract states that.
Yes, sir.
And so what will happen is that, you know, we'll probably ask either county commission or operations money, you know, to cover that $10,000. You know, so it's not a big gap, but I'm just saying.
Okay, do I have a motion to approve?
Motion.
Second.
Any further discussion? All in favor?
Aye.
All opposed? Next item. Let me see. Courtney, you got anything else here?
I don't know if you want.
You probably want to, I don't think we have anything else right now because she has the risk management at the end of this meeting, so.
I know.
And that's it. We just provided the ACLS, BLS, and PALS classes. Melanie was able to take care of getting a lot of that paid for through Career Source, so super thankful for that. That's a large chunk of money we didn't have to pay. And Melanie worked to get that taken care of for us. Got those classes, got all our nurse practitioners in the clinics. They took the course as along with the RNs that needed it during this time. So that was taken care of last week, so. Other than that, like Colleen said, we're looking at, I think, of June 18th right now tentatively for that hospice date, but once we nail that date down, we'll let you guys know.
So the other thing, Courtney, the only last thing I have, Courtney, is get Colleen the contact information for the rep that sold you this product so we can hit him up for the foundation.
Okay. She was gonna get on the call. I actually talked to her this morning, but she's at a doctor's appointment. Her husband's having a procedure. But she said she's welcome to talk, she'd be glad to talk to any of you that had questions. Her name's Cindy, so.
Okay. EMS update, Mr. Osteen.
Good morning.
Good morning,
Morning.
James.
All right, county transition still set for June 1st, as last I've heard. Haven't heard anything else on it. They have interviewed for the captains on last Friday. They've made their selection on Monday, so that the new captains have been selected. Looking down into the monthly transports to facilities, for the month of April, we transported 10 patients to Gulf Sacred Heart, 34 here to Weems, 11 to Bay,
You
10 to
transported
Gulf.
from where to Sacred Heart? Where'd they come, from the hospital to
No.
Sacred Heart?
From their home, from 911 calls to
Why?
Sacred Heart. The patient preference.
Is that what we're doing?
We can't refuse them. We can offer them to go to Weems. They don't want to go to Weems. We can't make them go to Weems.
We can't what?
So I've looked into this a little bit
Okay,
too.
my wife got in a wreck in Wakulla County several years ago. She wanted to go to one hospital, certain. They said, no, you go here on this ambulance or you don't go at all.
Well, they're in the wrong then. Patient
What
has
if
the
I want
choice to go where they want
What
to
if I want to
go,
go to Jacksonville to the hospital?
within reason.
Where does it say that?
Where does it say they have to come to Weems?
Well,
I thought
that's the
it's-
question,
should-
the question.
Obviously,
Well,
it's
shouldn't it be,
Weems
shouldn't it be,
ambulance.
shouldn't it be that, you transfer to the nearest receiving facility? Now, that's what I always
You what?
thought. Usually it's like you transfer to the nearest receiving facility, and
Yeah,
then,
I know.
and then if they don't, if they make a fuss about it, they sign a waiver. They should be signing something saying if anything goes wrong with your care, you're responsible. We're not. Is that right, James?
Yes, if they're offering, if it's a basic call, they can be seen at Weems, and they refuse to go to Weems, they sign a refusal for recommended destination, and knowing that the hospital or the insurance may not pay their bill. But we cannot force them and kidnap them to take them to Weems.
I didn't say kidnap.
I don't
Well,
think
that's
it's
for
kidnap.
forcing
I
them
didn't
is
say
It's not kidnapping.
I ain't said kidnap at all,
Well, let's-
I just
well,
know
let's-
what-
well, but
I
this-
just know what happened.
Well, this is something that we definitely need to,
hadn't said
this is something that we
Somebody
definitely,
else is in the frame.
I
this is
asked a
something that we
question.
definitely need to talk about, and we can
Okay.
talk about with James or the new EMS director. We really can have that conversation here. I don't know if we want to go through all this
No,
public meeting.
I'm through with that, but
Yeah,
I
but-
just wondered, do we charge them more to take them more miles or anything?
They'll
Do we
get the
get more
billing.
money?
They are charged by the mile, yes.
Oh, we do?
Yes.
Okay, okay, I can live with
They
that.
have a base fee and mileage.
I've never understood that, okay.
But we want to
And
make,
and as you said, they may have to pay that out of pocket
Yes,
rather than insurance if they just decide to go somewhere else. right?
correct.
And they know that
Yep,
up front.
yes.
that,
We,
hey,
we let them know up
Yeah.
front. And then we get
Okay,
that signature
that's
from them.
Yeah.
And that's
fair.
even for not just Weems, but I mean, that can be to go to another facility. If they're able to come to Weems and they opt not to go to Weems, then they are responsible for, or they could be responsible for that extra mileage.
Right.
essentially.
yeah,
Right.
but I just want to make sure we clarify this. We're not kidnapping a patient. We don't do that. I just want to say that publicly. So, I know that was used here. We cannot kidnap. There's no such thing as kidnapping somebody.
No, I didn't say
So I
that.
just want to make sure we clear that
I
up.
didn't say that.
Yeah, 'cause we don't want any issues
I just want to understand how it works,
here.
I understand it
Yeah.
better now.
But what we can do, like I said, of course, we have a new EMS director on board. Of course, we have some conversations with them, because what I want, when the EMS goes to the county, we still want a good partnership with EMS, the hospital. We still want to make sure we have a good partnership with EMS. It took us years to build that here, with Louis being the EMS director, to build that partnership with the hospital, because at one time, the hospital and EMS just didn't flow right together, to be honest with you. So we want to make sure that relationship is still there, that we have a good working relationship with the EMS director, and, we may set up some monthly meetings with him and Courtney, and maybe Dr. Conrad, so we can just be on the same page, as well as with our clinic personnel as well. Go ahead, James.
As I was stating, we had 10 also go to Gulf Coast and Panama City, 23 go to TMH, 6 go to Capital Regional in Tallahassee, and 9 were life flighted.
Nine on life flight?
Yes.
Wow.
We've had some critical patients this month.
Yeah.
Are those tourists or are those locals, James, that you're seeing life flighting?
Just
A mix?
mix.
Yeah.
Overtime is up. I've had a bunch of people taking time off because of this transition. I've had 648 hours of call-outs this month, this last pay period. I covered it with 412 hours of overtime, just to keep 3 ambulances on the road.
So explain that to me, why all of a sudden they decide to take time off?
Because I believe, it's in my belief, I don't know for a fact, but I believe they are not going to stay with the county. I don't believe they're going to continue with the county. I think they're going to leave the agency. And that's just my belief, because they're burning their time. And most of the time, if you burn your time, that's pretty much telling that you're going to leave. You're not going to stay.
So am I understanding this correctly? They were all for wanting to be under the county umbrella, and now that they're getting ready to go under the county umbrella, they're now saying that I'm gonna go burn up all my leave because I don't plan on being here. Is that the way the message should be?
That's the way it's looking, Mr. Berry. A lot of them aren't really understanding, I guess, that, the pay, the way the pay is gonna be. It's a lot less pay because of the because of how you got to include the new floor retirement, which costs a bunch of money. So we've had a it's compromise essentially.
So you had 600 hours of staff being off, but you was able to cover it with 400 hours.
Just to
That's a good
keep
job,
just
bro.
to keep 3
I don't know how
ambulances
you
on the
did
road.
that. Good job. Good job.
Well, to the tune of $17,000, but I mean,
I know, but that's a good job that you did that.
Well, we've been,
Was there any time that we were left without service in the county?
no, not because of being down in the ambulance. Now, there may be a couple of days, a couple of instances where we've had all 3 ambulances on calls. It may have been delayed getting somebody back to them, but nothing detrimental.
That's good.
Well, my problem was taking somebody someplace besides Weems. Okay. Say Bay, have we taken patients to Bay? So what's the time involved in us being down one ambulance in the county versus coming
Depends
to
on how
Weems?
busy Bay is when you get
That's
there.
how long we're sitting and
It
waiting
depends on how
room.
busy Bay is when the ambulance gets there.
It's the same.
Somebody told me last night they had 40 bed holds and 9 strokes on the wall.
What's generally done?
Generally,
can't
if we can
predict
get in
that.
and get out and get back.
3 hours?
Hour and a half, and you have 3 hours.
3 hours. Okay. Okay.
TMH is longer than that.
Always.
Oh, yeah, yeah, I'm sure it is.
Because, it used to be we could take them to triage and drop them
Drop
off
them
out in
off.
the waiting room, but
No.
they're packed now.
Yep.
Yeah, I
That's
know.
correct.
TMH is just,
They're holding patients in their triage rooms now.
yeah, they are.
If they sign a waiver to be transported to another hospital, and there is an accident in that process, who is liable?
Are you saying if they're recommended to go to Weems per se, and they
Refuse.
refuse and sign a waiver and saying, they want to go to someplace else?
Who's liable for the EMS personnel and that patient if an accident occurs?
No, I don't believe that's going to change at all, because it's with the patient. I mean, we're here for what the patient wants.
Those patients that were being transferred to Bay, James, are those your more critical patients that you know? Are you getting a bypass from the doc at the ER that says no, they need to go?
We're not getting a
Yeah,
bypass from
that makes a
anybody.
lot of sense.
We're,
Okay. So are those more critically ill
Those are the-
patients that
those
you
are-
know that you have to transport to
Those are
Bay?
the ones that are more than likely going to be transferred from Weems to
Right.
someplace. So we
So
just
you-
skip
That's
the
a good idea.
middleman,
Yeah,
skip
you go ahead.
the,
Correct,
with the
and you
doctor,
save the
sure.
patient time.
yeah, just saving time.
That's right.
What could be a heart attack. We don't know. It's
That's
not showing,
right.
but it's presenting something's not right. We're going
That's
to take
right.
them to someplace
To a
that can
higher
treat
level
them.
of care.
Correct.
Yeah, that needs to be called ahead, exactly. That's a good policy.
Well, that's what
right
he's
there.
saying it is. I have all the faith in the world that you and your staff are trained enough to know that a patient is critical and they need a higher level of care. That's what you do.
Typically, if we take them out of the county, they're needing
It's
a higher
because they
level
needed
of
to be
care.
there. I agree.
Other than Sacred Heart.
I agree.
Sacred Heart is just no more than the same level of care as Weems.
Right.
So if they go over there, it's because patient preference, and they refuse to go to Weems, I'd rather them go there than not to be seen at all.
I
Something
agree.
happen.
I agree. But your Bay and TMH patients normally are more critical and they
Bay,
need that higher level.
All the other 4 hospitals
Mm-hmm.
are, and obviously the Lifeline are more critical.
so either way, we just got to make sure that when a new EMS director come on board, that we work together, continually, because, we want patients to be seen appropriately. And we don't want to always say dollars and cents, but, there's always revenue out of our pockets, to pay for our EMS staff, but we're not seeing them here. So that's something to think about, but we want to make sure we continue a good relationship with the EMS. We'll meet with the EMS director to make sure we got lines of communication staying open, but we also want to make sure that we take care of the people that live in our communities.
Well, April 9th, my 82-year-old grandmother fell. She lives in Carabel. About midnight, she was confused. She didn't know where she was. Your staff picked her up, you brought her to Weems, and they did an amazing job. So did Dr. Conrad. He kept her for evaluation and kept her right across the street, or right across the hallway from his office, so he could watch her for me all night long. So I want to tell you and your team, thank you very much, because you guys were you were amazing. She was confused, she was scared, and your team did a phenomenal job, and I want to thank you for that.
Thank you.
And we always talk about EMS, the bottom line, if you need them, just like ED, you know, you can talk about IED, but if you need services, you want to
Yeah.
make sure they show up
Right.
and take care of you.
All right, let's move on. Anything
And the only
else?
other thing I have for you guys is, I called 3 of you guys, and Mr. Walker called 3 of you guys. And just to let you know, for that instance, with a violation of policy, that employee has been terminated.
We can't get into too much on, in public.
Yeah,
because
yeah,
it's,
we'll talk about that at
yeah.
the risk management meeting.
Yeah.
Yeah.
Yeah, that's risk management there, okay.
Thank you, James.
Thank
We
you.
appreciate
Thank
you
you.
so much. Thank you, James.
Next item is RHC update. Susie?
Good morning.
Good morning.
Susie.
Well, how to follow that one up. Okay. Just a quick thing that of course, it's tourism time and the clinics are getting a little busier, but we are also positively growing up in Carabel as well because of the growth coming down from Crawfordville. So we're seeing more outside labs and outside x-rays. So we're going to adjust appropriately. So it'd be a great time for the pharmacy to come in and all that's going to work well together. Don't forget when you all are talking about money for the pharmacy, about that bus that's going to deliver drugs. And, but I also want to understanding though, with people with the staff that are at Weems with this growth, we still have the same number of staff, okay? I just got in another nurse. But I don't think that patients understand at the beginning of the year, insurance has changed. A lot of patients, especially with administration, changes with Medicaid and services and pharmacy coverages, that has all changed this year phenomenally. Costs have gone up, people have dropped their insurances. They've changed insurances multiple times in just these few months. So with that, staff has to So we're primary care, right? Primary care sends a referral out for everything because we have nothing in our area. There are no specialists in our area. So you have to consider each patient has 1 to 2 to 3, even some of them have 5, 6 referrals. So there's a referral, which is just the recommendation for them to go to a specialist. That's one process. And then you have to make sure that that specialist is contracted with that particular insurance, which we don't know, right? Because a lot of specialists have gone to the point, because we're growing so much in the area altogether in Florida, they're capping off their patients, right? And they're not accepting more Medicaid patients, or they're not accepting that particular contract, because just like us as a primary care, specialists also change their contracts all the time with insurance companies. And Florida contracts with different Medicaid plans all the time. With that said, also the referrals come to prior authorizations. Prior authorizations for medications is a nightmare, especially with the weight loss drugs.
It's a nightmare.
I've been doing it for the last couple of weeks with my staff so that I can help support till our nurse comes on board, and it is gotten really challenging.
Yes, ma'am.
And they've done a great job, the staff keeping up with that, but I'm just putting out there to the public so that people understand the process. It's not a matter of just pushing a button. It is a matter of finding a qualified specialist that will take you on under your current plan. And oh, by the way, it's not a blanket plan for all Blue Cross. Everybody has these little marketplace plans that have caveats to it. You might have more money coming out of your plan for prescriptions as you do for care or radiology. Everybody's is different, and no, we don't have them all memorized. So please be patient with the staff. You know, if it's urgent, you definitely will go to the front of the line, but you also have to understand if you switch up a pharmacy, this is a classic example that we get all the time. Oh, I don't want to go to that pharmacy anymore. Now I want to go to this pharmacy. Can you switch all 12 medications to this other pharmacy? And then you're back to the square one of the process. So I'm just asking everybody, understand that about all primary care offices. It is a challenge, and it helps us the more information that a patient can provide to us about their insurance and the correct insurance. And no, we cannot get on the phone and call the insurance companies for you. That's a HIPAA and also an insurance contractual thing. We would love to help you as much as we can, but we just can't do that. So just be patient with the ladies in the clinics. We're growing with you, and we get you the best that we can. If anyone has any questions about what's being done, they can certainly call me. I'm happy to take those calls. Again, the pharmacy bus, right? You got that? And then the only other thing I want to add is we always take the time to thank us, but I want to thank the board and Alliant, because you all do a serious commitment to Weems, and I've been there 9 years, so I think that that's a great thing to see, this growth and this progress. And sometimes we feel picked at, but it is really great to have you committed to us, so thank you.
And I think that's very important. You know, many times, you know, we always say what we're doing, but we won't be able to do anything here if it wasn't for the leadership and the staff that have to do things. You know, we can pitch the idea to you all, you know, but if the staff, the leadership team are not really being our arms and legs on any of the initiatives, nothing will be done. And I really think that the staff, you know, since I've been here since 2019, of course, I've been on the board. I thought I was doing pretty good as a board member, but I guess probably not. But I think the board really support the staff. But it's very important as we talk to the public, you know, begin to highlight the work that our staff is doing, you know, because that's very important.
Tell your staff, Susie, hang in there, because from a provider point of view, I know exactly what you're talking about. I spend 50% of my day, and so does my nurses, seeing patients, and the other 50% is filling out referrals that get sent back, prior authorized PAs that get sent back. I had a patient on Ozempic with an A1C of 8.7. She clearly needed to be on Ozempic or Wegovy. We got 5 PAs from her. I had to fill out a PA 5 times to get her approved for her Ozempic, and her lab work was there. The numbers were there, so they advertise it. Oh, it's so easy to get your insurance. That is not true.
Right.
So from a provider standpoint, I completely understand what they're going for, and
Right,
it is incredibly frustrating.
Yeah.
And there was a prior authorization. That's what the PA means for some of the board
Yeah,
members.
I'm sorry, that means your
Yeah, 'cause
insurance. You
it's
send
like-
out a PA, the insurance looks at it and they say, no, we don't like it, we're not gonna approve it, and they send it back. So we do it again, and I think the goal for them is, well, they'll eventually get tired from it and they'll give up.
Right.
But those of us that mean that we're gonna do what's right for our patient, we don't give up. So tell them, I appreciate them greatly,
Yeah,
because
and
I
also,
understand.
people don't understand all the forms that the providers
don't.
have to fill out, and the providers get on the phone peer-to-peer reviews sometimes to help push for that drug.
That's
So
right, that's right.
That's great on them, but anyway, just to let you know that. Any
I understand
questions about the
completely.
clinics? No?
I got a
Thank you
question.
so much for what you do, Susie.
Is there a kind of little excitement over in the Carabel area about the pharmacy? Have you,
There is,
Picked up.
there is.
We were on the news, Duffy.
huh?
We were on the news.
WCTV, I believe.
Yeah.
Yeah, I got that.
Yeah, I think it'll be a positive thing. It'll be helpful for patients to stay on with their track with their medications, especially if we have a bus.
Okay, thank you.
Thank you so much, Susie.
Yeah, Duffy, let's take a break.
Okay, good idea. Let's break for about 5. Next item on the agenda is the plant operation report. Mr. Gibson, Craig Gibson.
Yes, sir. Good morning.
Good morning.
How are y'all doing today?
Or is it afternoon?
Yeah, or afternoon? No, not yet. All right. Topic here is CT construction. It's going very well. We're going to have a ACA walkthrough May the 6th, which is next Wednesday, I believe. And then on May the 15th, we're going to have a walkthrough for us at the hospital. The May 6th with ACA is an 80% completion part of the project, and then they'll do 100% when we get through the final. Not with the CT equipment in there, but just the room. So we'll figure that out as we go. I know we all know we have finally received the approval letter for the new generator to be installed and fuel tank. I've been talking to Gary Gargis, the architect that has drawn it up for us, Matt Taylor with Ring Power, that's going to be designing and fabricating the new fuel tank that's got to go on there, and James Lamb, the engineer, electrical engineer, and Mike Cates. So we're all starting that conversation and trying to start moving along with this. So hopefully by the time we get our CT equipment, we'll be able to bring the wiring over and hook it up to the new generator, because they're going to have it hooked up so we can, kickstart it and get it going. And so radiologists can get in there and start training on it also.
What's your time frame on that?
I don't know. As soon as I can. Yeah,
ASAP?
Yeah. No, well, that's why I started that conversation as soon as David passed me that paperwork for that earlier this week, Tuesday, I believe is when we got it. So I had already started that conversation with them. So Mike Cates, of course, he jumped right on it, because there's a couple of things he's got to change within the ceilings that they kind of pointed at. They want to change out. But as far as I know, that's pretty much it. They have actually already run their wires through the hospital to that room down there. So that's the biggest part. Now, the other part is in the electrical room. They've got to add one more transfer switch. They want 5 instead of 4. So they've got to run all the wires to that, get the innards, as I call it, to them, the breakers and all that put in there. And there's a lot left to do. But I'm hoping as soon as possible.
Yeah, but it's very exciting, because I'm getting calls already. When will the new CT machine be in?
Yeah.
But the room is already pretty much done. At least 80% of the room.
Yeah, 80% is done. Yeah.
Done. My old office and everything, we remodel that. But we're getting some calls already. People want to know when we're going to get the CT machines going. Yeah. The ACA visit will be very important. The next month will be a very important month for the CT machine. But once we do that and get the generator up and going, and get the equipment in, and I think the equipment may be settled to come in maybe in July. I believe so. Yeah, something like that. So, so it's very exciting. It's a long time coming, so we're excited about that.
Yeah. We're also working on. I've got a quote for through our grant that we had to replace 2 doors, entry and exit doors over at Weems West, the clinic over there. They're in bad need. The front door is starting to sag. So that's about 12 to 14 weeks out. But we're working on that. We're also working on with Evan Turkle of Oliver Sperry. He's going before ACA for us to remodel the 2 bathrooms on the hallways, patient hallway, to make them walk-in showers. So we've got that going on. I believe he's got to stand up with them either today or tomorrow, but he'll give me a call and let me know how that goes. Probably toward the end of May, we have the nurse call system that's going to go in the ER, which we didn't get the first go around. So that's going to be installed so nurses can see a call light come on if a patient in the room needs something, they don't get there. That's coming. The end of May should be going in. I don't remember the exact date, first of the year, we got an update from FHA notifying with the Florida Department of Transportation about the helipads all being brought up to date by 2030, July 2030, I believe. So we've already started that process. I was talking to Steve Kirschenbaum, who's over the airport. Met with him the other day. He's going to get his guy that works with the FDOT to come out and tell us what all we need to do to that, and we'll start that process. I know we got to put lights up, put the flagpole up, and paint it, whatever they need us to do. So just as soon as he lets us know what we're going to do, we'll follow up and proceed with that.
How many other locations do we have throughout the county, though? That's,
You know, I don't know what they're going to make them do. You know, Lanark, they have the little asphalt pad, they have a sock up there, and I think they have a light that shines down. I don't know if they'll make them comply with that or what. Most of your airports do it. You know, you can land at the airport. Our big thing is if we have a patient in the hospital, we transport them out to our helipad, because it kind of be, I don't think we can do it legally, take them from there and then go to the airport. I think there's a rule there that you can't do that. So, but that's
so
why-
we're only responsible really for our helipad.
That's correct.
And the county might be responsible for the other helipads if they have to bring them up to code.
Could be,
Okay.
yeah. But, you know, you think about it, they just land at the sheriff's office. It's just a dirt field with nothing.
Exactly.
So, you know, you've got a couple places like that. So they may not, you know, interfere with them at all. I think it's just because we're a hospital, you know, so. But, and I've all, go ahead.
In speaking with the people at DOT, my understanding from them was that all pads had to be brought up to stuff.
That's what I read, so, but I don't know. Only one I'm concerned about is mine. But I have also talked to Robert Mixon with Duke Energy, and he's put me in touch with their new construction group for Duke Energy. We have orange balls hanging on those power lines up there where they're faded. You can't hardly see them. So I've asked them to replace those for me. And there's one other thing that they're going to do.
Those are over by the school too, aren't they?
Not that I know of. I know they're right there in front of us. I haven't looked at the school, but they're right there at our there's like 3 of them. Oh, the other thing is I've asked them to put some blinking red lights on top of those concrete power poles and see if they'll do that. That way it'll mark it a little bit better for that pilot coming in. Yeah.
Well, if we need any connections with DOT, we can always go to John Berry. That's his former stomping ground.
What did you say?
I said, if we need any connections at DOT, we can always come to you, because that's your former stomping ground.
No. I've been gone a long time. But I know what department it is. They do say my ghost walks around in my spirit.
I'm sure every time I go by one of those pads on the turnpike, they're taking my money. I'm sure I think about you, John. Those transponders.
Appreciate it.
Appreciate it. That's fine. All right, in front of y'all, I have a actionable item I need y'all to vote on. Been working, go ahead.
Question before you go.
Okay.
What about that door that's at the clinic? Did you say over in Carabel? Is that the door you're talking about?
No, at Weems West,
Okay.
next to us.
Okay.
What's going on with the door there? Anything?
No.
Oh.
I thought you said over there.
Oh,
but
no.
I started to say, maybe you ought to back off till we get the remodel.
Oh, yeah, no, these are the front entrance to Weems West, the door is sagging, and so we're gonna replace that, steel frame and all, and the staff door that they go in and out, is past due. So we're getting ready to put those in. You've got paperwork in front of you. It's PulseNet. It's about our TVs at the hospital. We've been dealing with awful reception, couldn't get any response kind of out of the service we have now. So I have finally found somebody. It's through DirecTV. The initial setup cost with the equipment is $10,000. It was $13,000, but we've got them come down $3,000. We'll recoup that in about 13 months. Right now, we're paying right at $1,000 a month for our service. This is going to go down to $280 a month.
Is this off the satellite?
It's going to DirecTV, yes,
And
sir.
I've had it for 20-some odd years, and it works excellent.
Is there cable in the ER TVs?
That's what we're
Do we
talking
have
about.
cable?
Yeah,
That's what I
that's- oh,
thought,
yeah.
okay.
Yeah,
Yeah, the
but
whole, well, it's gonna be the whole hospital, and it's
Yeah.
also gonna be the
Awesome.
clinic next door.
Because the
Okay,
service we
awesome.
got now is not working at all.
Okay.
Yeah.
No.
Awesome.
Hit and miss.
It's kind of pixeling all the time. And
Yeah.
then they just cut off, and it's, I can't get anything out of them. I
Okay.
can't even hardly get corporate to call me back.
And when you're laying in the bed as a patient, I
Right,
mean, I
that's
hate
what
to
I was
say
about to
this,
get
but
at.
TV and food are
It's
almost as
important,
important
sis.
as your meds and
I
your
agree.
nursing care.
I agree.
We hear it all the time.
Yeah, I agree. It's, I think that's a huge.
Almost, I said.
Almost.
But you can't imagine how much it affects the patients, and they have a lot to say about the good food and the bad TV.
Yeah,
Mm-hmm.
yeah.
One of the ones. Come on down.
I want to watch football.
And again, like Kristen said, we have monitors, TVs in our emergency room, 1, 2, and 3, and they've never worked,
Yeah.
as long as we've had them. And
Yeah.
we also have them in the lobbies, and the lobby used to work, I'm not certain.
So how
now.
fast are you anticipating, Craig, that we can get this done? Where will we have cable in the rooms?
That, and I'm not sure of, because
Okay.
once this is approved.
Yes, sir.
The guy, Todd, we've been in contact off and on every week for about 2 months.
So what are you
just
asking the
going over
board to approve?
Approve the,
The initial $10,000.
10,000?
Yeah.
To have a motion?
Motion.
Second?
Second.
All in favor?
Aye.
No
The
opposed.
patients, thank you. And I do
Yeah,
too.
absolutely.
Now, just remember,
Absolutely.
when the big storm comes, it knocks it out.
Well,
It's okay, it doesn't work now,
Right.
I was
on
gonna
a sunny
say.
day.
Yeah.
This is
And I know
important.
Duffy will be
It's
glad
very
about this,
Well,
we've been talking about
yeah,
it for a
but one thing
while.
about it is that, MediaCom, I should have said the name of the company, but, we pay $12,000 a year for that, so this, we
All right, we got it passed. Let's move on.
All right, go ahead.
Yeah.
Kind of moving
But
on.
this is going, for the hospital, they're going to get about 100 channels. They probably won't watch that much, and it will be local channels also.
That's good. That's
That
real
was
good.
one thing I
Yeah.
want to make sure.
They want
And
the
then
news around where
next
they're at.
door, because, something about how the electronics works over there, they're going to get about 46 channels, which they're not going to use all those channels
I
either.
think I'll get me a
Yeah.
TV in my little area in the clinic then.
No. He's going to want me to put him in TV now.
Y'all been teasing me about my age. Do y'all remember when you had to go out, run outside and turn the
Turn the
antenna?
antenna.
Turn the antenna.
Get the thing right.
You had to put a hanger in there if it
The
wasn't
aluminum
working.
foil rabbit ears.
Rabbit ear,
Back a little
tinfoil.
bit.
And your mother or father relayed to you. That's right, right.
That's
Now
it,
go
right.
back a little bit to the left. a little
Thank you,
to the
Craig.
right.
Anything else, buddy?
All right, y'all got any other questions, or?
no?
No,
Good?
everything you've made a lot of
All right,
improvement at that
if y'all do,
hospital.
y'all got
It's
my
really
phone
great.
number.
Thank
All right,
you.
thank y'all.
Craig, for
Y'all have a
everything you
great
do.
day.
We appreciate you. Thank
I
you.
appreciate y'all.
Tease me about my age. We've got somebody
I have a
else remember that,
question,
too.
a quick question.
Yes, ma'am.
With all the upgrades that it's going to be done to our hospital, which I'm glad about, it's a wonderful thing. What about the promise of a new hospital?
Ooh, amen, sister.
Where are we with that?
I think we need to, that needs to be an item, separate item. I don't think we can just say something. The board said they was gonna look at that next year, I believe.
But can
correct?
somebody answer her briefly? She's right. Well, where are we?
Yeah.
Well, I think,
We aren't nowhere.
Okay.
yeah,
Okay, that's the answer.
I think we ought to look at getting the pharmacy completed and then look at that and think, okay, let's go forward.
Yeah, I
And
think,
be real aggressive about it, you know?
but
That's a lot bigger project.
but
They
David,
promised it.
didn't you tell me
They
that
did.
the board?
They did, Mr. Loris, you're
That was
right.
on the board's agenda for
Yeah,
next year?
next year will be 20 years since the,
Since the capital outlay.
yeah,
I agree with you on that.
20
I
years
agree
since
with you on
the
that.
people voted for a new facility. But I think the county and the city of Apalachicola, I think the county said October 1st, 2026, that they
I
will
think so.
have something for the city of Apalachicola to say if they're going to either rebuild, renovate, or something to Weems.
I know there's a lot of
Hospital.
talk of the Ascension. They're waiting to be credentialed with CHP. That's a huge factor because most of our patients in this county have CHP insurance, and Ascension currently doesn't accept that, but that's changing. So that was one of the biggest setbacks, was the insurance credentialed.
But, so that's something we have to keep in the mindset.
Reminding.
Because people ask me, of course they ask.
But you're right,
everybody
Ms.
here
Loris, we need to stay
about-
on it. You're
with
absolutely
that.
right. I agree.
All right, next item, is the, CFO report. Ms. Foley,
All right, Bowen, you're up.
hope you got good news.
Oh, okay. Before the land of remotes, right? Yeah.
thought you were aluminum foil there. And the rabbit eater.
No, not where I grew up.
That's not on the agenda.
Except the county. It's not that gross. Load it up here. All right.
You said we bring it up on the business.
Guys ready?
Yeah.
Okay. I'm going to provide an update on the financial performance, for the, I'd like to just initially open the comments with, it's, we're 6 months into our fiscal year end. It's kind of amazing how time just keeps moving,
Yes.
fast on us, but 6 months into the year end, I know David's going to talk about this a little bit later as well on his agenda, but, our planning session is well underway with, individual who supports us, Belinda Minch, and she's working on, just learning more about the community, gathering market data and so forth, and building up her analysis. She'll be discussing and talking with each of the board members, county commissioners, and I do want to give a shout out to Colleen and Bill for their help in the community. I was able yesterday evening to interact with several folks in the community that I personally don't know, right, and got the pleasure and a chance to meet them, and everyone's discussion and topics related to the hospital and what are we doing, what's happening, what's next, what's going on. So I do think your comment about what are we going to do with the future of our healthcare, I think it is very, very important to start really considering that. And that planning session and strategy session that we're doing here in June, again, David, I know I mentioned this, we'll discuss more around that. But again, just an overview and some key updates or key drivers related to our performance. Again, we're 6 months into the fiscal year end. Some key drivers that impacted the month of March, March's financial performance. Our gross patient revenues, and again, I'm going to walk down the profit and loss or the income statement. Our gross patient revenues finished up $212,000 or 14% versus what we provided in the last March of last year. Inpatient revenues were the biggest driver inside of that. Inpatient revenues were up $183,000 with total patient days, patients in beds, up 27 or 42%. Now, this increase inside that number does include the swing bed program. And again, and you can see the statistics in your board packet, that the swing bed program is the largest driver of our inpatient activity. Of that 27, 25 of those increased days related to our swing bed program. It's up 58%. So again, great growth that we're experiencing within our inpatient activity versus this same period in the previous year. For the 6 months, and I want to just mention this as well, for the 6 months of this fiscal year to date, the swing bed program is up 183 patient days, or about 83% versus where it was the last 6 months of the previous year. So that's a tremendous, again, growth of the swing bed program. The hospital's overall average daily census, which does include some observation patients as well. Again, these are patients that are staying in the beds at the hospital, finished at approximately about 3.3, way the math works, patients per day are inside the walls of the hospital in a bed. And again, that is up versus, again, same, that's up versus what we performed last year as well. It's about a little over 2 last year. Mm-hmm. So we're holding about 1 patient or more per day on average than where we were in the previous year, which is, again, shows some progress and improvement. Now, outpatient revenues, though, were down about $32,000 versus the same period in prior year, and as I discuss each month with the board, included in outpatient does include our ER and our ER activity, and that is our driver in our decreased outpatient-related revenue. Our ER visits were down 43 or 10% versus this same period last year. Again, the hospital does, though, continue, we continue to see, about 12 ER patients per day. Again, that is very comparable to what our trailing 12-month, I look at this over a trend, run rate. I know we've had a lot of continued discussions, earlier discussions around this. It's going to be very important as we move into our strategy session to discuss the ER. David's got some updates later on to talk about the ER and the capital outlay monies that we can be awarded in this coming year. But I think it is, again, continued importance for us to focus on that. As I mentioned earlier, even some of those community discussions, the ER came up, about, what can we do and what are we doing? And David's going to mention some of that later on in his update.
David, let me just add also, the ER visits for the month of April for March was more than we had for the previous 3 months. So ER visits did go up in March compared to February, January, December. So we saw a spike increase there. I just want to add that.
And that trend should continue for how long?
Well, you got the summer months coming, so that's probably going to go up, I think, all the way, probably to the fall, could be.
Yeah, and we'll keep providing updates as we move through it. But yeah, David's right in those. In that, I think we looked at this last month as well. You got those peak times and peak areas that you do see more elevated visits than what we have. But we'll keep doing the comparison versus the prior year. Keep doing the comparison versus the trend, so we keep our eye on it. Imaging exams, when you look at all of our imaging areas, we did see an overall decrease in some, but again, ER is a driver behind a lot of that decreased activity. But we did see, again, our ultrasound and mammography exams, those continue to exceed our year-to-date versus our same periods in the prior year. Our rural health clinics, I know that Susie spoke about this earlier, though we were down about $5,000 when you look at it from a revenue standpoint. So not much down, but when you look at our combined clinic visits between the two East and West clinics, we were down. Our East clinic provider was out of the office for about 14 days, I believe it was, on vacation. I know Susie had mentioned that even in the previous month that there was going to be some vacation days being taken and so forth, which allowed her staff, some time to get a few things caught up within the practice.
David?
Yes, sir.
Well, one thing I just want to point out here is that, if you're looking at the non-operating revenues, grants, and contributions, we're at 1.5, and last year we were at 2.6. This does not capture the $1 million that we got back from DSH in April, correct?
It does not.
Right.
Does
So,
not.
I mean, that's in here,
Yeah.
but it's not shown here because this is the cutoff March 31st.
That's
So
right. It's
I just
not
wanted
in
to
those
bring that up,
numbers.
that
Yeah.
that's
Right.
skewed negatively for us, but
Sure.
if
No,
you
that's
add
great.
that back in,
Yeah.
we're going to look a lot better than it shows.
Well, when we get into April,
Yeah.
absolutely, when it gets
Yeah, I
recognized.
was,
Yeah.
I was gonna ask that, our cash,
Yeah,
that would basically increase our cash by,
$1 million.
Whatever we get.
Yeah, $1 million. I mean, and I got some notes here. As I'm walking through this, I'll give you those updates, but you're exactly right. I mean, when you see April and see the recognition of some of this dish activity and so forth, it certainly helped the cash. It was hurting the cash because it's delayed. Now it is impacting the cash in a positive way, very positive way in April.
more cash we ever had.
But just mentioning a few other comments as I'm walking through the P&L, our EMS revenues, I know James spoke a little bit about this earlier too, really strong versus the same period in the prior year. His billable trips, I think he did mention this, but they finished around 117 in March, and it was about 109 in the prior year, so they did have a little more billable trips from our EMS. Net patient revenues, what we expect to collect on all these revenues I just mentioned about what we're providing. Our net patient revenue finished up $88,000 or 10% versus this same period last year. Drivers, again, in that increased net patient revenue is our inpatient activity. Again, a higher acute level of service, higher intensity level of service, you do get paid more for those services. Operating expenses, as they continue to walk down, operating expenses were up $21,000 or 7% versus the same period. Personnel, again, our salaries, wages, benefits, any contract labor, premium labor, was slightly up when you look at that in comparison to prior year, but that slightly up is driven from the increase in volumes. David and Courtney and the team, they implemented this months ago, but they do look at a labor productivity tool they watch this consistently. It's reported out every pay period as well, the activity. They are, as of the last completed one during April, We did finish at 96% productive. Again, that is a solid performance for the organization. That does include overtime. That does include the EMS overtime that James alluded to earlier. That is impactful to the overall operations of Weems Memorial. Certainly, and when that phases out, that will improve, that area or that measurable as well. Pro fees, professional fees are up slightly or versus our same period last year. Again, I mentioned this in previous meetings. Back in October 25, we brought the ER back in-house with the Southland Group, same team, but just brought the fees back in-house. We're billing for those services now. Just a couple other brief notes here. Supply costs, you look at our chargeable med supplies from our lab tests was a big driver last year. It was nearly double in prior years, so you do see supplies down year over year. Also last year, again, in comparison to this year, in comparison to last year for our pharmaceuticals provided in our clinics, those were about 12,000 higher than the previous year as well. So a lot of that impacts and explains our variance between our supplies being down versus this time last year. Just a couple other notes here too. Purchase contract services, those were up slightly. Again, this March was the last month. We have obviously contract with an external audit firm to provide the audit services. Those were presented to the board last month. The auditor did. He also presented to the county. Obviously, there's fees associated with them completing the audit. So those are in March's numbers. And then as Mr. Zester was discussing there, as you walk on down the financial statement, when you look at total non-operating revenues and in comparison to last year, just 340B inside that number is consistent. We did see some 340B actually improvement year over year slightly. So that is still being very steady. But if you recall last March, we did and were able to recognize, you guys may recall Brian Hall with Car Riggs discussing us about the audit, but we were able to recognize around $482,000 last March, which is why that number looks a lot higher, from an audit adjustment related to grant revenues that went between hospital and county. And then we recognized that last March, so that's why you see such a big number last year too. In addition to that, I know everyone recalls this as well, last March the county did contribute the monies and so forth that was utilized to pay for the TMH, or the Tallahassee Memorial payable that was on the books. Those monies were then recognized as a contribution in non-operating as well, and that's around $500,000+. So when you add those together, that did look as a very solid, strong number, obviously in March of 2025 when that was recognized. So that's why you see that difference in that gap. So again, for the overall month of March, our March's month-ending performance on a consolidated net income, consolidated again includes hospital, EMS, and the clinics as well. Our consolidated net income was at a loss of $52,000 versus a budgeted loss of $45,000, and obviously falling short of last year because of what I just mentioned about the recognition of nearly over $1 million in income. So again, from a comparable standpoint, as Mr. Zester mentioned, when you look at adding back, if you wanted to, or normalizing those dollars from last year, very comparable performance year over year for the organization, and actually a slight improvement with those increased patient volumes. Some balance sheet cash flow related comments. When you look at the overall cash position, again, very steady. We did see a delay and have seen that delay throughout this year in those state fiscal year DSH payments, disproportionate shared hospital payments that the state of Florida does allocate out. It's not reflected in the March, but during the first week of April, we did receive basically two payments related to this, but we did receive our rural DSH payment in the amount of $788,000, as well as what Florida recognizes as our public DSH payment, and that's around $250,000. So net of those two combined, they're over $1 million in our DSH monies that we did receive during April, which again is great. I mean, it has been delayed, and from the state, and this represents from 24, 25 months.
That had been delayed, right?
It had been delayed, absolutely, and that impacted us.
So that our starting point for our next would be from the point that covered, correct? You
Well,
understand what I'm talking about?
yeah,
I mean, if we were supposed to get it in February or whatever.
Well, yeah, use the first quarter, yeah, state fiscal year is on.
So our next one should come
Should.
to that, okay, should. Okay, I know, okay. all right,
Yeah,
should. We don't know.
hypothetically, you'll want it.
You understand what I'm talking
Yeah,
about
yeah,
there?
yeah. Your state
What you're asking is this Q1 money?
Yeah,
This $1 million is Q1
fiscal
money?
year, it's fiscal
Or was
year.
it, or was it prior year money?
it's prior year, it's state fiscal year.
Prior year money,
State
so
fiscal year.
maybe fourth quarter.
So it was.
2025
Right, it was
money.
delayed, and you hope that the state fiscal year 26, 27 monies will be coming in back on normal schedule, which means we may get cash, we don't have to wait as long again.
Right.
They're not,
Okay.
they're not resetting.
Of course, they don't have a budget yet.
I hope, I'm just
Yeah,
hoping
that's
that,
right.
okay.
Well, how often do they pay?
It's yearly on the dish.
Huh?
It's yearly on the dish.
Yearly?
Yeah.
Okay, yearly,
Based
okay.
on the state fiscal year, and
So
they'll
we
award
should
the
get our
monies out.
yearly a little quicker
Yeah.
than
Yeah.
Yeah,
the point we're getting paid now, you know.
Right.
I mean,
And there was
we
delays,
hope.
again, this is statewide, it wasn't just obviously Weems, statewide, so every hospital in the disproportionate share program that receives monies, had monies delayed, so, and I know that was very important, and I recall Brian actually, even, Brian Hall at the Car Rigs actually mentioning that last, when he was presenting the audit, that had, when you look at the cash performance, that was a big impact to the facility on that delay of payment. So again, April's going to look great with the cash performance coming in related to that. But when you do look at total cash collections, again, this does include that. You do see that being down $765,000 through March, and that is because that cash didn't come in timely. It'll be much improved next month. But I do want to point out though, within cash, that's total cash, but within cash includes patient cash. And when you look at our patient cash collections, again, this is billing for the insurance companies and so forth for services, we are up $196,000 year over year. So overall cash down because of delays in dish, but our patient cash is up for the services that's getting provided and getting billed and getting collected. And that leads me into talking about days cash on hand as well. I mean, we did finish, both with grant monies and operating cash. Within our total cash, we did finish at 48 days. Cash on hand, that is up from 43 in the previous month. Certainly with the dish, next month should be a more improved number there as well.
Well, David, I'm assuming that the dish money is going to go into operating cash, correct?
It will be. It should be, because it's related to the operational needs of the hospital. That's great. What goes into, board designated type cash is cash, as David mentioned earlier, too, related to grant activities and so forth that we got to use we're obligated, right, to use on certain projects such as the Omnicell and CT Build and other things that they're planning to do. The patient AR, again, obviously always a focus, right, because getting those days turned and so forth. But I did want to comment, and from a positive standpoint, from the structure they put in place to address, revenue cycle needs. On our dashboard, we do capture a metric called DNFB, discharge not final billed. And so that's patients that leave the hospital. When does that claim technically or get completed and then billed to the insurance companies? That did finish the month of March at 3.5 days. That is at industry, actually, that's at or better than industry best practice. And that was a great improvement. Again, that helps speed up that collection cycle on getting paid for the services. So that was a really good performance from March.
While David is up there, part of my report is that we did a little restructuring within the finance area, meaning that our accounts payable, revenue cycle, and bank reconciliation. So, Heather used to deposit the money and then pay the bills. Then Jason, Sam would do the bank reconciliation. So what we've done, we got one person would pay the bills, accounts payable. Heather will focus more on revenue cycle because we got to get money in the door. And then the third person will do the bank reconciliations. And so that's kind of like help us with that segregation of duties, kind of deal. So accounts payable now is moved over to Sam, Samantha Henry. So she'll be working with the finance committee with paying the bills. That way we got it separate, because what we was finding is that besides the segregation of duties, that accounts payable was taking a lot of Heather's time, and we really need Heather's time to be getting the money in the door, working the claims. So that's something that we kind of just restructured, see how that works.
Very good. And, like David mentioned, I had a few notes on that, but he's, thank you for covering it. That was perfect. And then, when you look at, just looking at other liabilities in related areas, again, I know I say this each month, but we are seeing some of that movement now with the dish and monies coming in. So we will see some of the activity of recognizing that in April, so I don't want to jump too far ahead of us there. But, included in other current liabilities, this project related to Omnicell, those dollars, again, are reported as a liability. You get cash. Bill mentioned it. Mr. Berry wanted this broken out to see the difference between the cash versus operating versus basic board designated cash, which relates to grant projects. So we will see some movement as Omnicell gets approved and gets put into service. You'll see some releasing of some of those liabilities because you did receive the grant dollars. You are putting it into service. Now it is no longer considered a liability from that standpoint. So we'll see some movement in the coming months, which I'll explain that when we get into.
With CT also.
Yes,
sir. Any kind of capital outlay projects, we'll begin to see some movement on that.
Yep. And so we'll see some, again, some recognition, some movement of monies, and I'll explain that during the months as we get into recognizing, moving that money around. Capital, obviously we related any spend, right? Obviously those items get brought forward before the board. I'm glad we clarified that earlier about the less than 50,000 spend, because there will be some moving pieces when we get into the pharmacy and so forth. So I won't go into any details there yet until we get, as Mr. Berry said earlier.
Can you address, so the board is aware of it, the charges back and forth from Blue, how it affects our monthly billing?
Sure, as it relates to the pharmacy project, yeah. So currently, obviously, we do utilize, our support team from Blue to help address 340B related services for the hospital. They are under contract and do help the hospital with that. We do have, you guys all have met and saw Jason Prokopik and Alyssa Kramer. They were on the screen last month and they have presented and shared. Actually, I saw Jason's face published in an article here locally. But again, pharmacists, they do great work, they do a great job. They are helping with this Carabel project as well. As we discussed earlier, even with the architect related work and going out to bid or going to look to seek engagement for CEI related work, if we do choose to have pharmacy support to operationalize, develop and operationalize, there will be a separate engagement for that related service as well to help with developing and operationalizing, the pharmacy at Carabel. So we do need to keep consideration if there's CIE or CEI fees, a pharmacist to help develop and operationalize, there will be fees associated with those levels of engagement. But I do think, and as we stated earlier, those will certainly stay below the 50,000 threshold.
Okay, but the bottom line is Alliance management fee number will go up while they are involved, correct?
No, sir. No. To state that differently, management fee.
In the billing. I don't mean management fee.
Right.
In the billing. Alliance billing
separate,
to the hospital will go up as long as they're involved.
There will be a separate engagement related to that activity to develop and operationalize the pharmacy. That would be great. And again, it's based on the scope and needs of having a pharmacist help build and develop and build that out. I mean, again, all of it's up for discussion about how we approach it, but there would be a separate for that, just as there would be for CEI related services. So,
for example, if you had, if we use Blue and Company, which we're using a little bit now, but we have to bring them on as a separate engagement, that Blue and Company fee for the pharmacy bill out will be there, but then we'll need to know what that fee is, because when we're billing this out, we want to make sure that we don't everything don't need to be ate up in fees. We want to make sure we have more money towards
Sure.
construction, so.
Okay, that was included actually in the business plan. I call it business plan,
Yeah,
right?
it was.
That was included in there.
It was in
the cost.
operating expenses.
Okay.
Yeah, it was. To help
Pro forma, I believe
operationalize
they
it.
call, I just still call it business plan. Pro forma, that was included in the pro
It
forma.
was,
Okay.
and again, I think there were some estimates thrown in there to
Right.
help with
Exactly.
operationalizing it and bidding operating expenses. And again, it's in pro forma numbers. I mean, obviously, all of that's up for
Okay.
discussion when that time arises with those various engagements.
All right, two things. One, Courtney, are you the one that has been involved in the swing bed push to get it up, the numbers up like they are?
Yes, sir. I'll also contribute that to the physicians admitting more patients.
Say thank you to them and thank you.
Yes, sir.
Second, when you go you're going to extract EMS once it gets moved over, when we look at future numbers, so that the EMS, you understand what
I
I'm
do.
saying?
Normalize
That
it
it's
for EMS.
extracted from our monthly numbers
Yeah.
going forward, so that we've got apples to apples and not.
Yeah, that's a great question too. And yeah, I'll definitely put clarity around that as we move forward once EMS is extracted, because it will skew if you just look
Right.
straight on paper. We'll have to do some explaining, obviously, to normalize for that EMS activity. Yes.
It also affects the budgeted number.
It does, because the budget was run through March 31st. So the last 6 months, or each month that the EMS carries forward, April forward, into our numbers, it was not budgeted for the hospital. So, yeah, it would be a variance. Yeah.
Thank you.
Yes, sir. That's all I got, unless there's any other questions related to the month's performance. Again, April, yeah.
Yeah.
Fantastic. We got our cash from Dish. I mean, that had been a stress, certainly on the hospital and on many hospitals across the state. But I mean, that was a blessing to see that money.
David, the only question I had on here was with regard to our allowance for uncollectible accounts receivable. It seems to be about almost 31%. I've looked back through here, and it looked like November it was about 25, February is about 15%. Are we concerned about that collectible expanding?
I mean, obviously, concerned, yes. I mean, you're always concerned when you see, movements and shifts in your allowances. The allowance process, involves obviously a look back on historical, and then that number is adjusted each month, basically. Or actually looks back at your historical experience, and as months pass, that gets updated. I do contribute, and I do think that our allowances, as I mentioned earlier, when you look at net patient revenue improving, are, what's referred to as a yield rate and or a payment to charge rate is improving. It's improving because the acuity, as I mentioned earlier, is improving. So naturally, the more intense the services and inpatient-related services, it will start moving that percentage in a better direction. Typically, what skews that percentage and makes that percentage more at risk, quite frankly, is if you see market shift within payer mixes, more self-pay, more uninsured type population, and not necessarily seeing that as much. You're not going to see that in the inpatient type activity as much at all, because with swing bed related services, a lot of that is for Medicare or age appropriate patients in a lot of cases. So where you do see more rise in uninsured or self-pay type population is through the ER. Obviously, because you're going to treat anybody who has to come through the door.
But that's geared to, you actually got budgeted in that allowance a certain percentage, and if that percentage changed, it's still out there. When you start looking at it, it's actual. Has that actual
It's
number
actual.
changed?
That actual number does change, right? It changes as we update the allowances each month.
Are we
That's
going
correct.
down or up?
Well, it's as Bill just alluded to, it is going up in some areas, right? And I think that it's not going up in our inpatient activity. Outpatient, ER-related activity, it will increase with, again, the uninsured. And I think, did you just, I was trying to pull it up on my screen here to kind of catch up with that. You said it's 31% for
Yeah,
this month.
30.98.
Yeah,
Yeah.
and what Susan mentioned this earlier about people with the marketplace, a lot of people, they're off insurance because the insurance went up. And so, so you're gonna see a lot of uninsured because of that, and it'll catch up with us later. Like right now, we're probably seeing it more now. They go to the ED, they're uninsured now. Before they had an insurance and better, they was able to pay that, but when the prices go up, they.
Kind of what Susie was saying about the outpatient clinics and the people getting their insurance
Yeah.
pulled and unsure where they're going with the insurance and.
Yeah, or they stop paying because they can't afford those prices, the
Right.
monthly prices. And so now, but you will see that now, as we go forward the next few months. You probably
I just think it's something we got to watch
Yeah.
closely.
That date's monthly, and when you look at like you look at AR days, accounts receivable days, included in that, and again, and I mentioned this earlier, that the DNFB, which is the discharged, not final bill days, improving, insurance collections are improving. What a lot of that number inside days is the uninsured days that are still in there, right? And that's patients that, again, as that, this gets into the math of it, but as insurance turn improves, the higher level of your days remaining in your AR is uninsured or uncollectible.
Uncollectible. Yeah.
Right? That allowance percentage will hedge up, right? Because your bigger bucket of your money's in there is for the uninsured and private pay related activity. And that has a very, we typically get, I don't have the percentage pulled up in front of me here, but just historically, probably 4 to 6 cents on the dollar related to those. So that will naturally move that allowance percentage up as that bucket becomes more inside that. If I'm making sense with that. And we can certainly walk through the allowance calculation, help go into further details with you. And actually, I may want to recommend at the next finance meeting, committee meeting, kind of walk through the allowance so we can put, more context around that and explain that further.
So in other words, in layman's terms, as your accounts receivable increases, that uncollectible doesn't look as bad.
Percentage thereof.
That's right.
Theoretically.
Yep. If what's left in there is uninsured and private pay related, it's going to be a higher number. Yeah, it's just saying in layman's terms. The higher the uninsured, the higher the allowance will be. That is correct.
Very good report.
Yeah, thank you. Yep. That's all I got, unless there's other questions. Yes, sir.
Thank you.
Thank you.
They're getting tired over there, but we'll.
Hey, everybody's walking around. This is a long meeting. We got 5 minutes. 5 minutes. 5 minutes. 5 minutes. Next item on the agenda is the Alliance Management Report.
Oh, no, Duffy, you forgot about me.
CEO report, I forgot about you, I'm sorry. Go ahead.
Oh, wait a minute, what about the finance subcommittee?
Oh, yeah, Bill.
I'm
Finance
sorry, Bill,
Subcommittee.
I'm just glancing at that.
Oh, it might-
Sorry about that.
There we go. Well, we kind of covered a little bit about that in our meeting already. We talked a little bit about just separating out, and Mr. Barry wanted to separate out the cash that's operating cash versus cash that's restricted or being used for projects. So, if we look at the whole cash number, it looks like we got a lot of money, but when you look at what's restricted, the cash, money is a little bit tighter, especially when we didn't receive that $1 million from DHS. So I think that's smart that we're breaking it out that way. Thank you, Mr. Barry. He was also, you were looking at the phone bill too, from Consolidated, right?
Yes.
Do you have an update now, or do you want to wait till next finance meeting?
I haven't seen it yet.
Okay. All right, well, then we'll get that bill to, Heather can get that bill to you, I think. Maybe we should take a look at that and get that over to you.
Yeah, check your email, John, because I thought she emailed it to y'all right after. Okay, I'll check it. We'll double check.
Unless I missed it, but
Okay, we'll double check it. Don't worry about it. We'll get it sent to you.
tomatoes are coming in, so I might have missed it.
And then we went through, of course, the payables, and everything was fine. That's all I really have to say about the finance.
And we may talk about this a little bit more at the Finance Committee meeting, because usually we have to print out a whole lot of paper. So we may want to see how can we reduce some of that stuff and try to streamline it. There's some thoughts we can talk about during the Finance Committee.
Okay.
Well, we do want to have the original bills there in case we want to look back at something. The list is fine. I mean, that's
I'm
for
just
us
trying to think,
look at, but
if she have it on the computer, maybe she can pull it up from the computer if you need to look at it. But we can have more talk about it.
well, as long as we can access the bills and the back invoices on anything that we have a question on, then that's
Yeah,
fine,
yeah.
as long as it can be accessed. Doesn't have to be in paper. I mean,
Yeah, it's just, we'll talk about it, just, a stack of paper every meeting, it's
Yeah.
a lot of human effort in doing all that kind of stuff.
Whoa.
I'm just trying to think outside the box.
no, I agree with you.
Yeah.
Even though I'm kind of tactile and I like the paper, but it is a lot of work. So, yeah, as long as it's accessible, and if anybody has a question, we can,
Yeah.
pop up a laptop and get right to whatever that is that we need to look at. That's great.
Okay.
I'm good with it.
Okay, is that it?
Yep.
Thank you, Bill.
Let's move.
Next item, CEO report, Mr. Walker.
I think, John, you had a question?
Are y'all bringing in a packet of actual bills and all that? Is that what you're doing?
Yeah,
Okay,
yeah.
we figure a way around that.
All right, my report will be kind of brief, because I know we have to close in a minute. National Hospital Week, we talked about that already. Second item, outpatient physical therapy performer. Bill Zester would like this. We'll get the performer out the board pretty soon, and at the next board meeting, we'll go through the performance of starting an outpatient physical therapy program.
Really? We're about
That's
to
something
get
that we've been
looking
talking
again?
about for a while here.
Wow.
So Jason, had got some numbers together. We'll discuss that. We'll send it to the board. You all can review it. At the next board meeting, we will talk about that outpatient physical therapy program and essentially what we would do, and Courtney can jump in. We already have a area right now
I was
that
going
we
to ask
use.
what about the space?
Yeah, that we use for PT, physical therapy. And now we may have to buy a couple of more machines as well for that area there, but we have essentially an area right now in front of the hospital. We'll use that space there for our outpatient physical therapy program. And we'll start small, probably maybe 2-3 days per week at first, and then just see how how can we build that program up here. Courtney wants to say?
No, we will need a little bit more equipment, which will require a little bit more space, but we'll just go into that hopefully, and we'll find that space if we have to occupy some other place in the hospital. We have enough to work now, but we'd like to have, our therapist has requested one of the, like free weight machines. It's really just the stretchy bands, but it's a large machine. That would hopefully be our next investment in the therapy program.
Yeah.
What if we could partner with a local gym and do some of our therapy there? Have we thought about that?
We
thought
kind of
about-
talked to the gym one time when they were looking to relocate prior to the new East
Because
Point
East Point's kind of a central
location.
location, if we could partner
Yeah.
with them
Yeah,
and
yeah,
maybe
we have to
have,
see David with with the critical access hospital designation.
I think we talked about it maybe having to be on site,
I
but
don't know
I'm
about the
not.
liability
I'm
of
not-
that or whatever,
Yeah,
and
I'm
those
not-
legalities, but if we could partner with the local gym and get some of our therapy there.
Yeah, it's just that David was just saying,
Yeah, we'll have to look, as far
You
as an
can find a
outpatient,
lot of good.
outpatient
good
department.
Exercise
You know-
equipment in that, up there at that Tallahassee, at that place, people turn.
That's actually where our physical therapist lives, near Tallahassee, and that's actually where he sent me one that is just used, but barely used. So
Right,
it's
barely used.
Barely used piece of equipment, exactly what he wants.
Because some insurances will pay for a gym membership. I don't know which ones, I don't know specifically, but some will.
Yeah, and what we'll look at too, Kristen, is, with critical access, a lot of outpatient-related departments like that
Mhm.
need to be on the campus.
Okay.
It's just kind of, it's a requirement, and/or if you move off campus, the reimbursement structure changes on that.
I understand.
So we'll, look at the.
It's just an
differences
option
between-
until we wait for space or we run
Right.
out of space.
Right.
We're gonna discuss that pro forma at the next meeting, all
That's
right?
correct.
John has a question.
Courtney, you might want to, if you know what the future equipment type needs you might have, you might contact that person up there and owns that business and say, hey, we're on the lookout for this. You get something nice coming in, we'd like to have first shot at it.
Okay, I can definitely do that. I don't remember the price of the one that he had seen before and sent me, but you're not, if I'm guessing, I'm gonna say a few $1,000s, something like that. It wasn't crazy money, but I can definitely do that.
And I told him, we'll do what we can to invest in the program. We'll invest in it.
It's
'cause I
huge,
think-
we need it.
Yeah, it'll be.
We need it.
Be good.
Well, the other thing you gotta make sure you do is get it out to the public, make sure they know that we have these services. It's great to, build it, but if they don't know it's there, they won't come.
Yeah, because I can tell you, Port St. Joe's Sacred Heart has a waiting list for their physical therapy. We're having to refer patients to Excellence, which is another physical, and they're on a waiting hold too. So people from Franklin are coming to Port St. Joe for their physical therapy, so that would be huge.
Yeah. Either they going to Port St. Joe or they going to Tallahassee.
If you have CHP, you can't go to.
You got to go to Tallahassee,
gotta
so.
go to
I gotcha.
Tallahassee.
So that's gonna be big for us.
CHP, gotta go all the way to Tallahassee.
All right, let me go, let me just move through the items. We have the ACA Rural Transformation Grant, RFA was released June 10th. Alliant Management will potentially be the lead entity for the grant activities. Florida DOH, Department of Health, Pharmacy Residency Collaboration, Susie, Courtney, and I met with Department of Health Pharmacy Leadership April 15th, and they're launching this pharmacy residency program within the next 12 to 18 months. And we did tell them about the pharmacy program that we want to do here in Carabel, and so they indicated that they'll definitely like to collaborate with us with that as
Does it
well.
look like that's gonna,
Yeah.
okay, that's excellent.
Yeah, that's gonna be
That's
good. What they
work.
want, they want to give these pharmacists clinical rotation. So they really not only want them to work in a pharmacy, but they also want them to work through the hospitals, through the clinics, so they can be well-rounded, even in the ED, I think, something like that they were saying as well. So they can get a clinical overview about working in rural hospitals. And then I was telling them about the program we were doing, and one of the things they asked me, said, will it be part of your 340B program? I said, yes. He said, okay, that's how it can work. And so he was.
Part of their rotation, correct?
Yeah,
They have
yeah.
to take a rotation in a role.
Yeah, and so, they have to take a rotation. So what they're doing, Department of Health, they're building that out. And then we'll probably be the first hospital to connect with them, as a
To grab
rural
them.
residency
To grab
program.
them.
And so that'll be good for us, in what we're doing
That's wonderful.
there.
That's great.
The strategic plan is planned for June. The managers, the leadership team will meet with Belinda June 4th. The governing board session will be June 19th. And we're making plans to use the Trinity Presbyterian Church Benedict Hall.
Episcopal Church, sir.
Episcopal, my bad. Episcopal Church, my bad.
Now, Pastor Walker.
Yeah, I should know better than that, right? The Episcopal Church there.
Yeah, I think there was some question about the size of the room and the location. It's
good.
It's plenty big enough
Okay.
to house our group. So no problem. There's kitchen facilities in there too. And if we want to have lunch brought in or whatever, we should talk about catering with it.
All right, the oncology program, discussions underway, with Jeremy Hogg, about the oncology program, the cancer treatment program here. We'll be meeting with Dr. Conrad and Jeremy next week, next Wednesday, I believe, to talk more about the program. And then I bring Jeremy back here on May 2026 to talk about the inner workings of the program. So that's the
So
cancer.
it still is in process?
Yeah, the cancer treatment program here at the hospital. And this should be, part of it should be like an easy thing to do in the beginning, because really we're looking at a room to do some infusions in. And when we need to build certain things out, that's when we have to like do a little bit more planning with that. Just to let you know, as we begin to do these growth activities at the hospital, we're kind of like maxed out. I was telling the church, I like that growth space. Right now, we really have
As far as
outgrown space here in the hospital. So any kind of growth activities, we got to probably look and rearrange ourselves.
Yeah.
Because right now, we kind of stuck.
Maxing it out.
Maxing out right now.
We are maxed out.
Yeah, which is good, which is a good thing to do, to my point of view, because you're creating access to care. Anything we're doing, we want to create access to care. The last thing, the capital improvement grant, is going to be due on May 15th. One of the things we talked to Dr. Conrad and Courtney, and talked to David Bowling about doing a redesign of the ED, with that particular money. And then now we also can look at that front office piece, just doing a redesign of that. We'll see how much that costs. One thing about these grants, you're going to apply for a certain amount now. You don't have to really spend it until 3 years later because of capital improvement. So next year, depends how much the project costs, you're going to apply for the additional dollars for that. So we'll look at the redesign for the front office and the ED. I really want to redesign the whole ED. That's my philosophy, because that's a lot of patients coming in that area. It's just that when we do that, we'll have to move the ED to another location like we did with Hurricane Michael.
I got a question for you. We're talking about the possible construction of a new emergency room, standalone, I guess, or whatever. Would we want to find out what's going on before we redesign the emergency room? Wouldn't that be a consideration?
Before we spend that money?
Yeah, but
I think,
yeah,
I do
but
think, and I agree with that. We want that.
But the board want to hold off on that, because
I really don't know. I would.
The problem is this has been 20 years in the making. I don't think we can, I think we need to do some things to spruce it up. I mean, paint and some other things, move things around and just make it more inviting is not going to cost us an arm and a leg, and I think it's going to go a long way to the public perception of the hospital. I think we have to do some of that, even if it's going to be retreaded 2 years from now or 3 years from now when
what are we talking about?
We get approval.
What kind of money are we talking about?
How much money roughly?
Well, we have to do an estimate of what.
Okay, I'm just saying,
Yeah, because the grant's like
$400,000.
$400,000. Now we don't want to use the whole grant right now to redo that, because we're looking at redoing the front office part. But my thing is too, whatever improvements we make in the building, we're gonna stay in the building, meaning that even if you get a new hospital,
New ED room.
new ED and all that, you can still use that space for medical offices. We can
Or
bring
for rehab, physical therapy, or cancer center.
Cancer center,
There's plenty of
orthopedics.
things we can, swing bed,
Yeah.
continue the swing bed
All right,
program
we beat him
there.
into
Yeah.
submission now.
I'm just saying, whatever we do in the hospital, because that's a lot of questions come about. I get, Mr. Walker, why are we doing all this? We're supposed to get a new hospital. I'm like,
Right.
well, the bottom line is that we'll do what we can, and then we'll repurpose that space to something else.
I stand corrected. I'm fine. I'm good. I mean, really, I'm fine.
Yeah.
I had never
Just something to
thought
think about.
You need to get on his case like you get on mine.
No, he's not fulfilling you.
So that's just something that, we're looking at, if we do it, once again, if we move out that space to another new facility, we still will use that space for doctor's offices.
I agree. That's
Okay?
good. Very good.
All right. David, you got something else? Okay. All right. That's all I have.
Okay.
Correct. It's good. It's good. Very good. All right. Anything else, David?
No, you got Michael Kozar.
Michael Kozar's on. There he is.
How you doing, Mr. Kozar?
Good morning, Michael.
Good morning.
Morning.
I don't have much in the interest of time. I know David touched upon this with the Rural Transformation Grant. And, we are currently working with our grant writers to be able to respond to the first issuance of those initiatives that the state put out. And we have about till mid-June to respond to that. As David mentioned, we initially had looked at, two hospitals kind of being one kind of the lead applicant, and the other one being the manager. And in consultation with our grant writers and that, they felt that it probably would be best served, since four of the 7 hospitals that are currently expressing interest in the collaborative that's being formed, to have Alliant be the lead applicant for the grants for all these individual hospitals. And so we're finalizing the agreements that would be in place to make the collaborative. Now, as we've developed and said this all along, every hospital will have a vote in this, and all the actions of the grant process will be approved by all the hospitals that are involved with this. So we're just serving as the point person to be able to apply for the grant and to supply some of the what I anticipate, the voluminous amount of information that we're going to have to provide back to the state and to CMS on any of the initiatives that we apply for the grant. So just wanted to touch base on that. Hopefully this week, today or tomorrow, I'll get the final draft from the attorneys to be able to distribute that out amongst the hospitals so their legal counsels can then review it. But we are moving forward right now, looking at the telemedicine and telespecialist components of the grants that were released to be able to start aligning what services that we could hopefully expand in each one of our rural communities by the use of the telemedicine and telespecialist support that we may be able to get. So the only other thing I just mentioned, I know, with the state budget, that is held up, and the issues that were going back and forth between the state of Florida and CMS on the DPP program, which affects a lot of hospitals in the state of Florida. That has been resolved, and one of the requirements is that hospitals had to sign attestations to be able to do that. So, for the hospitals that are getting the DPP money, we're hoping that sometime mid-May, we should see some of those payments coming through. But just, the budget for the state of Florida hasn't been approved yet. Still a lot of focus and efforts to try to prevent our state legislators from reducing the Medicaid reimbursement in any way to our facilities. So we continue to put, pressure on our legislators to ensure that, the funding sources for Medicaid remain stable as we move forward. So those were real briefly, just the items that I wanted to touch upon this morning. I'm happy to answer any questions anybody has.
Mr. Kozar, I suspect you're going to play a major role in the BPP money and the consortium of 7 hospitals that's put together to try and attract as much of that grant money as possible. Is that correct?
Oh, yes. Yeah, and that's, we meet weekly now, and Mr. Walker's been an active participant in those meetings, and trying to look. We have used Ovid as our grant writer. They have a lot of experience. They've done a lot of work with Calhoun Liberty and Doctors Memorial Hospital in securing grants for those facilities, and they have the expertise to know what needs to be written in these grants to be able to qualify for them. So yeah, we'll be taking a very active role, as far as making sure that, and the bottom line is what we're trying to do is get as much of this of these grant dollars to the hospitals, because our hospitals, unlike what some people believe, we are the center of healthcare for our communities. And, it's vital, that we protect these dollars to come to our communities for the purposes that we need to improve our communities, and not have them going to consulting firms and all these outside entities that are all vying for the dollars that are coming in. We've had discussions with FSU, with some of the medical, the health-related programs, whether it's Chipola College or any of the other schools that are in our region, to be able to do the workforce development, to be able to attract more nurses, more therapists, more lab technicians that we desperately need for our community. So, yeah, we'll be taking an active role in trying to secure these funds. I mean, it is, the first batch that they sent out was over 270 pages of information to go through to qualify for these grants. So it's a complex mechanism, but we're doing everything we can to try to ensure that our hospitals play or all 7 hospitals, I don't mean just the Alliant hospitals, but all 7 hospitals in this collaborative have the best chance to be able to funnel those dollars for what's needed in our communities.
And we thank you for that.
Thank you, Mr.
Thank you,
Kojar.
thank you. Looks like we were on top of everything. Thank you very much.
Do you have a chart that shows previous history as far as grants awarded to the 7 different hospitals, as where we stack up in that hierarchy?
We don't have that, but John, that's something that we probably could put together here. I know some hospitals have been very successful. Other hospitals, and I'll use the hospital in Chipley as example. They because they're a for-profit status, they qualify for very few grants. But we could probably put together a list of some of the grants that the other facilities have been able to obtain through the last, most recently, I would say.
I'm just being parochial. I'd like to know where Franklin County and Weems stacks with the other 7 hospitals with regards to fund these grant dollars.
Yeah, I think previously, we were probably one of the most rural hospitals that apply for grants. We have a list of different grants. Some hospitals were not as proactive. I think we've been proactive since I've been here 2019 in getting grants. Some hospitals really don't get grants. Some recently have gotten grants within the last 2 or 3 years, but going back to 2019, we really applied for a lot of different grants. But a lot of hospitals really don't go after a whole lot of grants.
Well, it should show which hospitals have been more successful than others. I mean, all of them have been successful in some degree, but then what are the best practices? Why are they getting the dollars?
Well, I think it depends on the focus. As a CEO, I focus on leveraging dollars, so my mindset is always try to get grants. Some CEOs, hospitals, that's not their focus on trying to leverage grant dollars.
Well, and the other thing, to add to that is, and Weems and David have been very strong in getting grant dollars to Franklin County there. But, in some cases, and I'll use Calhoun Liberty. I mean, a lot of monies that they've been able to get recently were related to their hospital and hurricane recovery.
Right.
Same scenario over in Taylor County there with Doctors Memorial. So sometimes it's a matter of what their needs are and what they can qualify for too. So, but I do have to, again, outline, David Walker and what he's been able to do to secure grants for the organization. He's, again, probably one of the stronger hospitals we have as far as being able to get those dollars funneled to the community and to the hospital.
So, and he should be stronger now that the Doctors Memorial doesn't have their CEO anymore, right?
Well, yeah,
Unless if they don't try to hire me, I'm just joking.
See, I-
You're frozen.
I don't know what you're talking about there. Okay.
Okay, we're
Well, I
on,
think everything's going well.
yeah, we're on John Barry.
Thank you.
Carabel Retail Pharmacy report.
Yeah.
Thank you, Mr. Kozar.
thank you.
Thank you,
Thank
Michael.
you.
Thank you.
Thank you. You want me to say
No,
something?
Duffy, I was going to
It's
look at
your
the agenda.
turn. Pharmacy.
Damn, I thought it was, whole meeting was my turn. Wait a second.
Carabel Retail Pharmacy Report, John Berry.
Well, we met last week, number of us on the phone and in person, did a walkthrough, basically came up with a floor plan, I guess, a design that the Marvin Heyman, the architect, has put to paper, and I think he's got a lot of it already done, but he still needs to communicate with Jason Prokopik and Alyssa, is that her name? Alyssa, to make sure that the i's are dotted and the t's are crossed, and then once that plan is put together, we'll bring it back here and let y'all take a look at it and say, hey, yeah, this is good, or no, this is bad, whatever. But that's the key right now, to get that finished. And then Marvin Heyman is an architect, and he's very good. And he has said that he would be interested in being the CEI of this project, which would be great because he's the one that designed it, therefore, or helped design it. He would be the one overseeing the contractor that we go out for. But now that's going to be the big hump for us. But the meeting was good. We got quite a bit accomplished in a short time. And right now, I'm just taking and cracking the whip to make sure everybody continues to communicate, and we get a sign off as to what this is the way we want it.
And just let everybody know that the next meeting is going to be the 18th, right? May 18th.
May 18th, is that what?
Monday, May 18th is
Yeah.
what I think we
Where at?
settled on. At the East,
Yeah, May 18th, 10 o'clock.
Clinic East.
Wait, what?
It'll be the
18th.
It'll be the
Monday, the
meeting of
18th in
the-
May.
Our board meeting,
No, that's when we're going to have the next meeting for the pharmacy. Pharmacy meeting.
and it's going to be there.
Yeah, so if anybody wants to,
Right, 10 a.m.
Okay. Well, that's got to be published and everything. John, I don't know any more capable hands that could be in. You know, one thing I'm concerned when we talk about a contractor and stuff, I wonder how busy the people are, if they can jump right on it and do it. I mean, that's gonna have to be a stipulation, you know, we got some deadlines that we have committed ourselves to, basically.
Sooner we get that document and we get it out there.
the sooner we can get somebody on it.
And I'd like for it to be somebody local that has those capabilities, you know?
See, I have no idea how busy they are.
I don't either.
Oh, it'd be wonderful to be local here, you know, and what we're gonna require for the contractor and stuff like that, I guess that'll be in the bid. Anything else?
New business,
That's it right now.
new business.
Okay, I have no new,
I do.
one new business I do.
Or do you
Go
do or I
ahead.
do?
Well, you go ahead.
I'll bring it up. We've been talking about this, and obviously, with Mr. Kozar talking about how involved Alliant is with getting us that big, beautiful bill money. They're operating 4 of the 7 hospitals that are involved in that consortium to get the money. They've been a great partner to us for the number of years that we've been on consulting with Alliant. They are on a month-to-month contract, and I think it's despicable that we keep it that way. They're doing a lot for us. They're putting stuff forward for us, helping us with the pharmacy, everything else. I think we really owe it to them to put out a 6 or 12-month policy for Alliant moving forward, so that they can feel comfortable that, we're behind them as much as they are behind us.
Well, didn't Commissioner Amison bring that up at the last
He did.
BOCC meeting?
He did.
Yeah,
And
so
I
they're on
think-
board with that.
And so I think what this board should do at this point is say that we do recommend that, and
And we
let
in
the
support of it.
BOCC make a decision on it. So
We're in support
this
of it.
board could recommend it moving forward.
Well, I don't think, we don't have an agenda to vote for that.
Well, we're not voting for the contract go forward. All we're voting, well, if I put a motion forward, my motion would be that this board thinks that there should be an extension of Alliance contract to 6 months or 1 year
Well-
on their, whatever their pleasure is,
I know.
but have them, the Board of County Commissioners,
Actually vote.
actually vote to have it approved, because we can't approve
We
that.
can't approve that.
We
The
can just
BOCC has
recommend
to.
it to the board.
Yeah, let me just
We can't have a vote. However, I talked to Mr. Morone and about this, and he suggested the board's not gonna have it on their next agenda because it's so full. It's gonna be on the next one right there.
There you are.
But I think that if we need to, the board wants us to come back and vote for it, we'd be happy to. I don't know that it's gonna take a vote. I don't know there's opposition to it. Michael?
It's fine. I mean, if you guys want to send a recommendation to the board.
Okay, that's
Yeah.
fine. Well,
So my motion is to make a recommendation for Alliant to, we extend Alliance contract beyond a month to month to month, whatever the pleasure
Whatever-
is of the
whatever
Board of
pleasure
County
of the county,
Commissioners. Recommend 6 to 12 months, whatever they want to
whatever
do.
the county would be
You're
comfortable with.
supporting, you're
Yeah.
supporting what Commissioner Amerson already said. so-
Correct.
Yeah, exactly. So,
Put that as an email, memo, whatever you get, that's fine.
okay, so we don't need to vote for that.
I think
Okay.
If the board is, if there's a consensus on the board, you guys want to do that, you nod, you say.
Is
yes.
it consensus?
Consensus?
Yes,
Yes.
I
Yes.
recommend we
John-
do it, say 12 months, because we still got that 30-day,
45 days,
Yeah.
30, how many?
45,
45
yeah,
day.
termination.
Yeah,
They got a
Get out of the
45 day
yeah,
out.
yeah.
Contract is only as good as an out clause is.
That's correct.
So, yeah. So David, just send me an email and the board supported that.
Okay.
Yeah.
Thanks, Mark.
And I'll tell you what, I'm very happy with the service we get from Alliant. You look at everything we've done, and we don't need to talk about all that, and we have they're personally involved with us. I don't think because a lot of things we did, the CEO has done an excellent job, and I'm real happy with everything. Okay. Any other new business?
No, I mean.
I have no new business. This meeting's adjourned. In 5 minutes, we're gonna have the